Hello, everyone. A very warm welcome to all of you. I behalf of the ASMRCOG team, I welcome you all. I'm Dr. Sana Nazif, one of the mentors at ASMRCOG, and we are very delighted to start this journey with all of you. A very beautiful journey of MRCOG 3, and we hope that this journey, we wish, we pray, we hope that the journey that we all are starting together, it's going to bring some happy news for all of us in May attempt. So the first module that we are going to start today is early pregnancy care. And as you all know, I hope you all have well prepared the module. So there are some things that I want to discuss with you before I can proceed on to the stations. For today's class, we have got 8 stations and there are going to be 7 to 8 presenters. The drill is that the station will appear on your screen and 2 minutes will be given to you to read the station. And afterwards, 10 minutes will be given to you to present. And after 10 minutes, you will not be allowed to continue the station. And then 5 to 8 minutes will be given the feedback to all the participants. So as we are proceeding on to the stations, one thing I would like to mention to all the participants and the candidates that for the listeners as well as the active participants that 5 domains are the most important part of MRCOG 3 exam. These include communication with patient and relative and also information gathering, communication with colleagues, applied clinical knowledge, patient safety. So today as well and in the coming sessions, you will be given feedback on these 5 domains and we will be guiding you throughout that how to improve these domains because you have to ace these domains so that you can get the passing score. And first of all, some domains are quite difficult, but we are here to help you. We will be telling you the tips, some precious things that you can do to ace that domain. But patient safety and communication with patient, these are a little bit difficult domains. And we are here for you. And we are here in your journey towards the MRCOG 3. If you feel any difficulties, you can contact us anytime. You can send your queries anytime in the group and we are here to support you throughout this journey so that we can have a bright result at the end. So I guess all the participants have joined. I'm just waiting for a few listener participants, but we can start with the first station. Dr. Nazish would like to share her views and I will just ask her if she wants to give her any expert opinion about the domains and today's module. Dr. Nazish, please. Hello, thank you so much, Dr. Sam is basically very critical. Candidates, you are welcome to ask any question if you have before we start the session regarding any domains or any history question, any early pregnancy care module questions you are free to ask, and then we will move on to the first session. Okay, so I guess, oh, so Core, are you ready for the first session?
Yeah, sure.
Yeah. Okay. So, Core, the station will appear now on your screen, and I will start the timer. You have 2 minutes to read the station, and then I will tell you when to start, and then you will be having 10 minutes to present the station. And after that, feedback will be given to you. Would that be fine?
Okay. All right, sure.
Okay, sure. So, first station you are going to now. Here it goes. Everyone, please remain on mute because once the station is over, then you would be allowed to speak. So, please go on mute.
Any next page? Any other page? Any other page? Yes.
No, this is the all. I'll just show
All right.
you the slides again.
Okay.
This is first slide.
मम्मा मैं याद करी थी मम्मा ने मम्मी
Everyone, please go on mute. Please go on. Okay. So, Core, you can start now.
पापा जी मम्मा ने मेरा मुंह बंद
Right.
किया
Hi, I'm Dr. Kim, one of the doctor in the early pregnancy assessment unit. Today, may I confirm your name and age, please?
Hello, doctor. I'm Lisa John.
How should I address you?
Yeah, Lisa is fine. I'm 26 years of age.
Hi, Lisa. I'm gathered the information that you are currently having a problem in terms of your vomiting. Is that right?
Yes, doctor, that is right. I'm having severe vomiting from the last 1 week.
All right, I'm sorry to hear that. Is it okay? Do you need any medication for your vomiting currently before we proceed?
No, I'm okay, doctor. The nurse just gave me the medicine and I'm okay now.
All right. Lisa, this is my first time seeing you today. Do you mind if I ask you a few more questions so that I can understand you further before I formulate a management plan with you?
Yeah, that would be fine. Yes, yes.
All right. Lisa, how is the pregnancy so far?
Pregnancy is going quite fine, and I did the pregnancy test at home, and it came out to be positive, and I was so much excited about it. And me and my partner, we are very happy to welcome our first child. So we are very happy about this pregnancy.
All right. When is the last period you have?
Yeah, I guess it was 8 weeks ago.
8 weeks ago. All right. So when is the problem started? The vomiting, the bleeding, when does it started?
Yes, I told you I have vomiting from the last 1 week, and the bleeding was not a problem. It's just from the morning I'm having a little bit of bleeding.
Okay. And then have the bleeding, do you notice any blood clots or any vesicle on the bleeding?
Yes, yes, the vesicles were there, and I was quite shocked that why the vesicles are there. But I thought I will discuss it with you. Some vesicles were there.
Okay, sure. And Lisa, do you know about your blood group?
Yes, it's B negative.
It's B negative. Do you know how about your partner blood group?
No, I'm not aware of his blood group.
Oh, okay. All right. Lisa, do you have any feeling of like fainting episode, feeling dizziness currently?
No, nothing like that, doctor.
All right. Do you have any tummy pain?
No, nothing like that, doctor.
All right, Lisa, any problem in your medical condition that you need to visit your GP?
Yes, doctor. Basically, I'm a patient of celiac disease.
Okay. Any other problems?
No, just this celiac disease I have.
All right. Any past surgery before?
Sorry?
Any past surgery that you have before? Any
Uh,
surgery you have done?
no surgery.
All right. Do you smoke, Lisa?
Yes, I do smoke.
How much do you smoke?
Yes, previously I was taking 5 to 6 cigarettes per day, but once I came to know that I'm pregnant, so I've reduced it. Now I just take 1 to 2 cigarettes per day.
All right. It's good to know that you are taking less of your smoking because it doesn't do good to your pregnancy.
Yes,
Um,
yes.
do you taking any alcohol or any illicit drugs?
No, I don't take that.
All right, Lisa, thank you for your information. Do you have any other allergies?
I'm allergic to penicillin.
You're allergic to penicillin. What happened when you take your penicillin?
Yes, I have vomiting and rash.
Okay. Is this your first pregnancy?
Yes, doctor.
All right. Thank you for the information given, Lisa. Any other things you want to add on before I proceed?
Uh, no, I think that's all, doctor.
Okay. I gather the result and the ultrasound result that they provided to me. I confirm your name and the HSS number. I'm sorry that I might not have a good news for you, Lisa. Do you have anyone you want to accompany you today?
Uh, what has happened, doctor? I've come alone. Is everything okay?
So the investigation showed that you are pregnant. However, it seems that you might not have a normal pregnancy going on. You have a condition that we call a molar pregnancy. Have you ever
But
heard about molar pregnancy?
no, doctor, what's that? I haven't heard of it ever. Is it a normal
Okay.
pregnancy? The baby is there, right?
I'm sorry to tell you that molar pregnancy is not a normal pregnancy, and your pregnancy might not be progress into a normal baby.
What you're saying, doctor, we are so happy, and you're saying this, I'm not having a baby. So what's it then? How is that
Okay,
possible, doctor? I was
I'm sorry,
completely
Lisa.
fine.
Yes, sorry to tell you that you are the bearer of this bad news because in a molar pregnancy, there is a genetic imbalance in the pregnancy that is occur in the beginning of the conception itself. For example, for a normal pregnancy, there is a one egg and one sperm. They fertilize and they share the balanced genetic material, and then it will result in the baby and it progress normally into the normal baby. However, in your condition, we call it a molar pregnancy. That means there is a imbalance genetic material. It might be due to the fertilization occur with only the sperm and the empty egg from your side, which might have a problem in terms of it won't develop into a normal baby, and it will end up to be posing a dangerous symptom to you. It will explain why you have this vomiting, why you have feeling of this per vagina bleeding. That's posed the problem currently.
So, doctor, can't we wait that it can normalize, or can't we wait a few weeks and to see whether the baby is forming or not?
I'm sorry, Lisa. I hope that I can tell you the better news, but this pregnancy might not end up in a normal pregnancy despite waiting for 1 or 2 weeks. However, what I can offer you today will be that I can offer you a management plan with my consultant, and I will manage based on your symptom because from the result, it showed that you have some level of low salt in your body. It might be due to your persistent vomiting that will might need to admit you for a proper hydration to correct all the electrolyte imbalance in your system. Is that okay, Lisa?
Okay, yes, doctor. I'm so much depressed at the moment. I'm getting it.
I know that the uncertainties of this condition pose a very stressful for you and your family because you are happy to hear about this pregnancy. However, I will facilitate you with this pregnancy so that I can offer you a better management care so that it be safe to you and hope that next time you will have a better pregnancy outcome.
Okay, doctor. Okay.
Okay, for
So,
now,
yes, so
yes,
doctor,
yes,
can
Lisa.
you? I have celiac disease, so can you just give me some medicines for this? And by medicines, I can get better. What do you think? Because I have a celiac disease.
Yes, you have a celiac disease for your vomiting. We can give you some medication to prevent the vomiting. But basically, the main vomiting is mainly due to the molar pregnancy itself. So this molar pregnancy, there is an abnormal pregnancy tissue in your womb that we need to remove it in the operation theater. Basically,
Okay.
what we, yes, Lisa.
Okay, doctor. Okay. Yes, I'm getting it,
Yes.
doctor.
Mm-mm. Basically, we are doing in the operating theater. We are inserting a suction tube gently into your vagina and into your womb to remove all the abnormal pregnancy tissue, and we send it to the lab for the confirmation of the result that's showing you have a molar pregnancy. However, the
Okay.
molar pregnancy, the outcome is generally good if you have a proper follow-up and management. Hence, I will put you and I will register you under the specialist center who will have a proper follow-up and coordinate your management with the expert in the field. Is that okay, Lisa?
Okay, so doctor, it won't happen again, right? When I get pregnant again, it won't happen again.
The risk to happen again is low. Hence, if you have a proper follow-up and you've been followed up with a serial number of pregnancy hormone, if it go down normally, then generally you have a low tendency to be happen again. I will show you, I will give you some patient information leaflet and give you another appointment so we can discuss this further if you have concern, and you can bring your partner along if he want to know further about the management of this molar pregnancy. Is that okay, Lisa?
Okay, and doctor, after you treat this condition, when can I get pregnant again?
Generally, you after the whole follow-up, depending on your whole pregnancy hormone level, after 6 months, you can get pregnant again if everything goes into normal without any problem.
Okay, okay. Thank you, doctor. Thank you.
All right. Thank you, Lisa.
Time's up. Time's up.
Okay.
Okay. Okay, so Kim, it was a very good attempt. I must say you tried to cover every aspect, and I'm quite impressed because based on your first station and first module, it was a very good attempt, and your empathy was very good. You were allowing the patient, you were involving the patient with yourself. So first, I will be telling you some good points, and there are some things to improve that we can improve together. Okay, so coming to the first domain, first I will start with the information gathering. History was quite good. You took the relevant history. You ruled out a topic that is very important point, and you took the history about bleeding. That was a very good point. Some things were missing. You could have a little bit asked more about because you have to rule out the hyperemesis gravidarum. You could have asked that in the last 1 week, have you considered any weight loss, or have you seen any weight loss, any clothes of your have become loose. One thing that was missing. And whenever a very important thing is that whenever a patient of molar pregnancy come, we have to rule out the GTN, gestational trophoblastic disease. So you have to rule out, are you having any cough with the bleeding or with bloody sputum, or are you having any headaches? So these two things you always have to ask to rule out any gestational trophoblastic disease. You have to rule out in your history. Are you with me, Kim?
All right. Sure.
So these two things were missing, and in molar pregnancy, there is always history. Sometimes patients present with raised blood pressure, so it's better to ask any other thing you want to add. Any raised blood pressure was there apart from vomiting? So this was these two things you can add in your history. One is about the GTN meds you can rule out, and the other is you can also ask about the blood pressure. Okay, so information gathering was fine. In medical history, when I told you that I have celiac disease, you could have asked her to little bit elaborate. Whenever a patient gives a history of medical problem, always you have to ask her to elaborate. Like, since when are you diagnosed with this condition? And are you regular with your follow-up to the general practitioner or to your medical specialist? Are you taking any medications for it? And are you regularly taking any blood tests done recently? Anything you want to tell me about the disease? So that was missing, Kim.
All right.
Whenever a patient ever tells you about any condition, you have to ask her to elaborate. Okay.
Okay.
So in history, very important point, reservations to the blood transfusions was missing. This is a patient safety point.
All right.
Okay. And in most of the examiner's key, if you don't ask in molar pregnancy a patient safety point like, do you have any reservations to blood transfusion, you fail that domain. Because in molar pregnancy, we always have to give blood before or during the procedure or after the procedure. In 90% times, we have to give blood. And if you don't rule out this, then this domain can't be passed. So this was missing. You could have asked the weight to height ratio because a patient is going for surgery, and you might have to post-operative care. You might have to give her some thromboprophylaxis. So you could have asked about the weight to height ratio. So this was also applied clinical knowledge point. So it can affect your this domain as well. Okay. One very important point in history was missing support. Sport is very important. You always have to ask that how's the sport at home? You can omit occupation because occupation is not going to affect. Sometimes it affects because obviously you will be for molar pregnancy, you will be doing suction and evacuation, and she has to admit in hospital for 1 week. You might have to write her the sick note leave. So it's better. You can ask occupation. However, we can compromise in occupation history, but sport is very important. How's the sport at home? Because you have to ask, you have going to admit her, you want support from her side, and she needs psychological support as well. Okay.
All right.
Okay, now coming to, so this was about the information gathering. So I will give you in information gathering, it goes 1 because the scoring is like 0, 1, 2. But I'll give you 1 because 2 to 3 very important points were missing. Okay, so this domain goes
Okay.
borderline. Okay, communication with patient, your communication with was very good. You was asking her, you were taking her along, your empathy was very good. And I would like to tell you that you can add few sentences like this. Like, Lisa, are you with me? Lisa, am I clear so far? Any questions so far, Lisa? Do you want me to repeat anything, Lisa? So these 3 to 4 sentences are very crucial to pass the domain of communication with the patient. So you can just write these 3 to 4 sentences, or you can just write them, and then you can learn and incorporate in your next presentations. Like, are you following me? Are you with me? So this domain, I'll give you 2. This domain is pass. Now, examination you skipped, but examination has, in some stations, examination has marks. So you can just say one line, is it okay I examine you in the presence of a chaperone? And that domain will be ticked. So you can just say this one sentence to get a tick on that. Now coming to the, okay, the next domain I would like to discuss, communication with colleagues. This got a little bit borderline as well, Kim.
Yeah.
I will solve a station for you all guys to see that how to pass this domain communication with colleague, because it has some many very minor points. You could have involved counselor. Counselors are very important because these patients, you could have told her that you will, one sentence you always have to speak in every station. You will be managed by a team of doctors, my consultant, the counselors, the psychological counselors, the specialized nurse, and the sleep doctor, anesthesia doctor. Whatever seems you better, you can speak that. So communication with colleague is very important in that regard, because these patients of molar pregnancy, they are at risk of psychological trauma and post-traumatic stress disorder. So counselor was very important in this station. So this domain, I'll give you borderline, but it can be improved in the next stations. Okay, so the management was fine because in exam scenario, we don't have so much time to elaborate on all the management options, but the management you gave to the patient, that was good. You tried to touch every aspect, like the vomiting aspect, the fluids, and then you told her that we are going to do the suction and evacuation, and afterwards that will be sent for the histopathology. That was all good, but you could have little bit elaborate on the follow-up, that how we are going. You told her the follow-up, but you could have a little bit elaborate on, and it is very important to say that we will register you in one of the gestational trophoblastic disease center, that is in Dundee, Sheffield, and London. One of the centers you will be registered, and there you will be followed up, and the follow-up is going to be like this. If it comes out to be normalized within 56 days, then we are going to follow up you for 6 months. If it is not normalized, we will follow you up from the date of normalization for further 6 months. Am I clear, Kim, up till now?
Yes. Yes.
Okay, so you could have little bit elaborate. Then contraception is very important in this station, because you have to tell her that you have once we follow you up and your beta HCG and your pregnancy hormone becomes normal, then you can use any other contraception. But till then, you have to avoid some copper coil, and you have to avoid some hormones because they can affect our follow-up. So you can just try to use the condoms. So this is very important, also patient safety point. If you have time, you can also tell the recurrence to the patient, because it was the role player question in the exam as well, and I asked you as well. So it's in the template as well. You have to learn it very well, that 1/80 is the recurrence chance in the next pregnancy, and NTD is very important in this station. So
Yeah.
this was your overall feedback, and according to me, three domains are pass, and two domains of your go borderline. Okay.
Okay. All right.
Okay. So overall, it was a very good attempt based on your first station. Keep it up.
All right. Thank you.
Okay. So Dr. Nazish will also give you a feedback on your presentation. Over to you, Dr. Nazish.
Hello, Kim. I was really delighted to listen to your presentation because it was really on point, and it seems like you have already been practicing. Is that so?
Yeah.
Yeah, your presentation was really having good points. There are most of the points, like 99% of the points you have missed, are already covered by Dr. Sana. There are just a few things that I would like to add on. Overall, the presentation was really good. And if we see that this is your first presentation, that this means that you are a very strong candidate for the exam, and I am very hopeful for you. So, here, as Dr. Sana has already mentioned, most of the points that you have missed, I am going to add up just a few more. The first thing was the blood group, that was Dr. Sana has already elaborated, because the blood group needs to be elaborated when you have to give NTD. First, I'm going to talk about the information gathering domain. So, as Dr. Sana has already told, the blood group was very important because NTD is also very important. In your guideline, you do study that if it is a complete mole, then NTD is not required. But generally, the concept is that it takes almost 72 hours for the histopathology report to come, or sometimes later as well. So you, until and unless you are sure about that, you have to give NTD. So in such stations, NTD has to be given to these patients. Kim, did you mention the histopathology has to be sent?
Yes, he
Yeah.
mentioned.
Okay. So you mentioned that. Okay. So one thing was that in the agenda, sometimes we come across many things that are usually crammed up lines. I found one of your lines like a crammed up line. Here, I would suggest that instead of cramming up any line in the exam, just try to be spontaneous. Like talking a thing about like we will come to a mutually agreed plan, and these things are a bit of like cramming, because most of the students that are going to appear for part 3 MRCUG, 50% of them will say these lines. So if you are going to be spontaneous, that will really add up to your score. Like if you simply say the patient, okay, I'm going to look at your investigations, and I'm going to talk about them, and I'm going to talk about your management, and so this can be a more good option instead of any crammed up line, because the crammed up lines are not only spoken by you, they are spoken by many candidates, and this gives an impression that okay, so this candidate has crammed up the station, so this gives a bad impression in the very start. So have you learned these lines, Kim?
Read about the few books.
Yeah. So
Yeah.
never cram them up in the agenda, okay? Because when the
Okay.
person is hearing 50, 60 candidates and you come up with any crammed line, they will immediately pick that up, like I picked that up, right? So you have to
Yeah.
be very spontaneous. Overall, you were very good. Like you were taking the role player with you. You were totally spontaneous in your presentation. So it was really, really good. But this was the line that I picked up that it seems like Kim has crammed it. Okay.
Okay.
Okay. And one thing was that the explanation does not carry a lot of text. It's just to explain the patient. And one thing can be like you can use a visual aid, like you can make the molar pregnancy, but it's your choice as well. Even if you don't make it, that's fine. But one thing is that don't speak a very long lines about the like explanation, 23 chromosomes from the mother, 23 from the father. If we can explain the patient in a very simple way, it is really better. Like you can simply say, okay, half the genetic material comes from the mother, half of it comes from the father, and in this condition basically a sperm meets a hollow egg. So this is the rule of it. Okay, what do you think about
Okay.
it? This will save
Yeah.
you 30 seconds at least. Will
Yeah.
it?
Sure, correct.
Okay. The reason is that see, currently your role player was very decent. She asked you just three, four questions, but the role players can come up with like eight, nine questions. So what will you do with the time? That's really a problem in exam. Okay.
Okay.
Okay. So cut down the explanation, just two, three lines about it, and you are really good to go. Its score does not really matter. So this is it. And in the one thing that was missing was, did you admitted the patient?
Plan to admit. Yeah.
Yeah,
Okay.
he's
So
yeah, but admit is very important line, because admit, if you don't admit, the patient safety goes borderline, because admit is always a patient safety point. You have to elaborate a little bit on that. We are going to admit you, so the examiner is able to hear clear that.
Okay.
yes, this thing was like, I didn't appreciate the admission, but if you have said that, that is really good. Then the thing was the contraception that Dr. Sana has already mentioned, because if the patient specifically asks about it, you have to tell her that until the pregnancy hormone normalizes, the copper coil or the combined pill are not the good options. However, barrier is a good option. But if you cut it down, you can simply say, okay, we will give you barrier methods for contraception. And one thing that was missing was follow up, as Dr. Sana has already elaborated. Apart from that, just the points that Dr. Sana has asked to add up, these are the points you need to add up. Apart from that, you can skip the other ones. And in the start, you can also say that you are going to give the patient fluid as well, because the patient is also dehydrated as per her investigations. So, apart from that, your presentation was really, really good.
Okay. So good job, Kim, and keep it up. And we hope to hear some amazing presentations in the coming yeah.
Okay, Dr. Sana, Dr. Amna had an emergency, and she said that one of the patient's placenta previous bleeding, so she might not be able to attend us today. She had three stations with us.
Okay, so next participant, let me see what who have joined us. Dr. Amara can present the next patient.
Okay, Core, you will not be leaving us. We might be having one, two stations more for you. Will that be fine?
Sure, sure. Can. No problem.
Okay, okay.
Yeah.
Is there any problem of time, or you will be available here?
I will be available.
Yeah.
Okay, that's
You
really,
don't have duty
that's really
tomorrow,
good.
right? You don't have
Yeah,
duty
no.
tomorrow.
Yeah, I
Okay,
don't
that
have.
would be fine. Yeah, that
All
would be
right.
fine. Okay. So we have got, let's see who have joined us. Dr. Mara, would you be able to present the next station? Dr. Mara, can you hear me? Hello, Dr. Mara. Okay, so who we have got next?
Okay, so this is station number 2, and this will be presented by Dr. Amara. Dr. Amara, are you available?
Yes.
Okay. So, welcome, Dr. Amara, to ASMR COG, and we hope that we are going to listen to some amazing presentation. And here, you know the drill. 2 minutes will be given to you to read the station, and after 2 minutes, I will ask you to start. And then after 10 minutes, I will stop you, and then the feedback will be given to you by me and by Dr. Nazish. Okay. Do you have any questions?
All right. No. The
Okay.
start.
Okay. So here's the station, and your time starts now.
आपके बैठे हैं
Okay, Dr. Mara, you can start now.
Okay. Hello, I'm Dr. Amara. May I check your name and age, please?
Yes, doctor, I'm Catherine Simpson and I'm 26 years of age.
Hey, Catherine. I understand that you had copper coil 6 months ago, and now your pregnancy test is positive. Is that right?
Yes, so some test was carried out for me, but I'm not aware of the report. So what are you saying, that is it positive?
Okay, we will discuss in a while. May I know that any other concern?
Yes, doctor, I'm basically I have a copper coil from the last 6 months, and previously I was having spotting, so my GP gave me some medication, and the spotting stopped, and I was okay. But from the last 2 to 3 weeks, the spotting got a little bit heavier, you can say, but the spotting was there. So I got a little bit worried. I went to the GP and he ordered some tests, and he said that the results will be discussed by you. So I some urine test was carried out for me and some ultrasound, but I'm not aware of the report and I'm here to discuss the reports.
Okay. So, Catherine, may I know that when did you feel your thread last time?
Yes, I'm able to feel the thread. Thread is there.
Okay. And uh, can you tell me that do you have any pain after or heavy periods? You notice anything
Pain is
previously?
pain is there. When since the copper coil has been placed, my periods are become a little bit painful. So I take sometimes paracetamol and then the pain goes away, but the pain is there.
All right. All right. Okay. So, Catherine, can you tell me about that whether this is your as already you know that you are pregnant and you had copper coil 6 months ago. So, what is your thoughts about continuing this pregnancy?
Basically, doctor, this has come as a shock to me because the copper coil was there, and I never thought that I got pregnant on this. But me and my partner, we don't want a pregnancy at the moment because we have a kid and we were okay with that, and we don't want a pregnancy for the next 2 years. That's why copper coil was placed, and it's a shock for me that I'm pregnant. I don't want this pregnancy. Just I want to get rid of it.
Okay, I let me reassure you that Catherine, your wishes will be respected, and me and my team are here to help you. Some more questions. Do you have any? Do you have any medical history, like you follow your GP for any other medical problem
No, I'm perfectly fine.
or any other family history of concern, like
No.
in the form of clots in lungs or legs? Okay. Do you have any surgery on tummy or down below?
Uh, no, doctor.
And are you taking any medications or are allergic to any medication?
No, I'm fine. I'm not allergic to anything.
Are you aware of your weight and height ratio?
Yes, it's 28.
Okay, and your blood group?
It's A positive.
And uh, any reservation for blood transfusion if need arise?
No, no, I don't have any reservations.
Okay, and Catherine, do you smoke or drink alcohol?
Yes, I do drink alcohol, but I don't smoke.
How many packs per day?
Yes, 1 to 2 per day.
Okay, and have you ever thought of quitting the alcohol? Because
No,
as you know,
no,
it's not
no, I haven't.
healthy for. Okay, Kathleen, we strongly encourage if someone uses alcohol that it's not healthy for your health. So, if you want, I can connect you to the NHS Stop Alcohol Services. Stop.
Okay, okay, I'll think
Okay.
about it. Okay, I'll think about it.
How is support at home?
Good. My partner is quite supportive, and we are a happy couple. Just that we were not expecting pregnancy, and now I just want to get rid of it.
I understand. So, mostly when let me explain you that when IUD is there, sometime it could be possible that it has been and it has been expelled on its own, and sometimes sometimes people are not aware of that, and sometimes it is a possibility that IUD is perforated from the wall of the your womb. First of
Okay,
all,
so
we will try to locate. Yeah.
doctor, why you
So
got if
first
I
of
had
all,
copper coil? If I had copper coil, why I got pregnant?
copper coil is although 99% effective, but sometimes there is a chance that if there is a 1% chance that someone can get pregnant, and along with copper coil. And if this happens, first of all, we recommend that this IUD should be removed. I Okay, are
Okay,
you with me?
okay. Yes, yes, I'm getting you, doctor.
So, and sometimes the coil is not well placed on or displaced from its sides. So, what happens? Copper coil is not causing pregnancy by if it is in proper place. But sometimes because of these heavy periods or pains, it can be displaced. That's why pregnancy can happen. And as we if you don't want pregnancy, first of all, we will remove the coil, and then we'll discuss with the options of terminations. How does that
Okay.
sound?
Yeah, that sounds fine. And so what options I have got, doctor?
So, I will discuss your options with my consultant also. As there is, we are having an options like if mostly sometime with IUD, and as your symptoms shows, it can carry miscarriage on its own. But other options are that you can go with the medicines, or you can go with the surgical management. And with the medicines, you have to take the medicines. There are some complications and benefits of that. Benefit is that you take medicine and avoid the instruments, and the complication is that might be the tissue remain there, and you may need the surgical management. Sometimes patient comes from home with a heavy bleeding, and with the surgical management, definitely it is a time controlled process. You are admitted in the hospital, and you come, and the process and it occurs quickly. So these are the two options. So what are your thoughts about?
Okay, so which one would be the quicker and which one you think would be better for me?
um, I think so. As you want you are 9 weeks pregnant, and you want to get rid of this as soon as possible. I am having these patient information, written information leaflets regarding the both the options. You can discuss with the partner as well, and both are safe, and both are having its own benefits and complications. I'm also arranging an appointment with the consultant. You can also discuss with the consultant. So now we can, as your decision will be the final, and as you say, we will proceed with that.
Okay, okay. And doctor, after I get rid of this pregnancy and and whatever management I choose, would it affect my chances of getting pregnant the next time, or will it have any other effect on me?
No, it doesn't have long-term effects. Although every procedure is having its own complications, but with the good hands, the complication rate is very low, and it doesn't affect more in future in getting you the future pregnant.
Okay, and any other problems can it cause for me in my future pregnancies?
Um, like if someone can get infection in the womb after the surgical procedure, or with this, there could be a little bit possibility that due to because of this infection, in that case, the I think so. Okay, very low risk of complications or in getting pregnant. Otherwise, most of the time there is no complication.
Okay, okay, okay. Thank you, doctor. Time's up.
Thank you, sir.
Okay. Okay, so Dr. Amara, first I will be coming to the good points and then I will be discussing the points that you need to improve. Uh,
Okay.
Overall, it was a good attempt. You tried to cover all the aspects that the Catherine came for, like she came to discuss if the reports and she came to discuss what options she have got. But there were some things that were missing in certain domains, and I will be telling you domain wise. Your intro was fine. That was spontaneous. That was quite good, but a little bit improvement in agenda needs to be done. Like you can say the agenda like this, that I have gathered from your GP letter or I have gathered from your notes that you are here to discuss your reports, your ultrasound report and your pregnancy test report. Is that right? So in the coming few
Okay.
moments, I will be discussing your reports and management options with you. But would that be fine that I ask you a few questions before that? And at the end, I will also write back to your GP and will provide you with the patient information leaflet. So this, if you
Okay.
see the agenda in this way, because agenda is also, you have to get that tick done for agenda as well. This was
Okay.
about the agenda. Some things were missing in the history. because she was whenever a patient has come with reports, you can never just discuss the reports in history. You always have to ask that what brings you here today, and you have may I know the concerns. Then the patient will tell that she has come to discuss the reports because the patient wasn't aware of her reports, and this is where the patient safety goes borderline, that you haven't asked the patient that why you have come here, and you have just started the history that you are pregnant, and the patient safety goes zero from there. Are you with me, Dr. Amara?
Yes.
So never start history from this point. Always, always,
Okay.
always question. Can you please tell me in your own words your concerns for today? Or a very good line you can speak. Like in my exam, one of my role players wasn't speaking anything, wasn't telling anything that why she has come. Then I asked her that what are your expectations from today's consultation? Then she started speaking that I am here to discuss my reports and I'm here to discuss the management options. So any sentence you can speak to make the role player speak, and then you can proceed. So it was better that you could have asked that, can you tell me in your own words what brings you here today? And then you can have asked the history. History was a little bit missing, but it could be improved. Like always try to make the history in a chronological order. Copper coil was placed first. Please mute your mics, everyone. Please mute your mics. Is not. Please mute your mics. Okay. So the first question, in chronological order, copper, you could have asked about the copper coil. That was good. You asked about the copper coil, that, and were you having any problems? She told you about that. Then you asked her to elaborate on the spotting, and you could have asked a little bit more about the spotting, that how many pads you have to soak, and was it associated with any clots, any vesicles, any disease spells, fainting spells. You could have asked that as well, because copper coil, is a risk factor for ectopic pregnancy as well. So this was missing in information gathering in history part. Obstetric history,
Okay.
I told you I have one kid, but you didn't ask details of that. So you could have asked the details, that how the baby was born, how the baby is doing now, and you asked about that, was it a planned pregnancy? But in my view, a better sentence would be that what are your and your partner's thought about the pregnancy? Once you reveal the pregnancy, then a better sentence is to speak what are your and your partner's thought about this. And whenever a patient comes
Okay.
with such problem like spotting, it's better to ask that, do you consider yourself to be a happy couple, and are you happy to proceed with the pregnancy? To rule out certain concerns, because sometimes domestic violence, they give in hidden agenda. So it's better to ask this sentence, do you consider yourself to be a happy couple, or is he supportive? So that is an important question in early pregnancy module, or in stations where the patient comes with the spotting. So rule out molar, rule out ectopic. This was important. This was missed. Then obstetric history was missed. Gynae history was fine. Medical history, you took it. That was fine. Surgical history was fine. You asked about the sport. That was fine. Be you could have asked, you could have just you asked her to add anything, that was fine. But examination you skipped. You could have asked her that, is it okay I examine you in the presence of a chaperone? Because speaking just one sentence will get you one tick, and that is very important. Examination, most of
Okay.
the stations, examination doesn't carry mark, but in some of the stations, they just want to see that whether this candidate is addressing the examination component or not, whether this candidate thinks that examination is important or not. So it's better to speak just a line, and never to go in details of examination. Never, 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 because it will not give you extra mark, it will just waste your time. Okay, so information gathering, I'll give you borderline, and communication with the
Okay.
patient, I'll give you borderline as well, because a little bit fluency would be better. And as I told Kim in the previous station, that try to speak these sentences. This will pass your communication with patient. The sentences are, any questions so far? Do you want me to repeat anything, Catherine? Are you with me? Or do you want me to repeat anything? Or do you want to ask any questions up till now? Are you following me? So these are some sentences that are very important. Okay, so
Okay.
uh, So once you have done the examination, then because the patient wasn't aware of the reports, so you could have asked that one sentence you can speak that, do you want someone to be with you while I proceed further? Or do you want someone to accompany you while I discuss your reports? So these are some sentences. Basically, this MRCOG3 is basically an exam of acting. The doctor is acting, the role player is acting, and whosoever is the best actor wins. So you just have to act. So the BBN, by speaking this sentence that do you want someone to accompany you, that domain will be ticked. Then explaining the reports in an empathetic manner, that is very important, because the patient was not aware of the reports and the patient didn't want the pregnancy. So you could have one sentence you can speak, because in my exam, the role player, when I asked her that was it a planned pregnancy, or do you want to discuss it with your partner, and she abruptly spoke, why I will discuss it with my partner? This is my body. I want to get rid of it. And why are you asking about it? So that was quite difficult to handle the role player. So it's better to speak one sentence. Look, Catherine, I respect your concern. I respect your choice. Whatever you choose for yourself, we are going with that, because every woman has a choice as to when, where, and how she wants to deliver. We are just here to guide you with choices, and whatever your decision will be, we will support that and respect that. So this sentence sometimes calms down the role player, because my role player in the exam was quite difficult to calm down. The patient was with copper coil with pregnancy, and she started just yelling at me that how with copper coil I got pregnant. How is that possible? So that was a very good answer that you gave. You told her that 99% it's effective, but in 1% it can be pregnancy can be there. That was a very good. I also gave the same answer. This is a good answer, but you can, all of you can write the failure rate of pregnancy with copper coil is 20 by 1000 for 5 years, and this is you have to quote in the exam, that 20 by 1000 for 5 years there is a failure rate. It means that 20 out of 1000 women can get pregnant even on copper coil. So you can just write it down. Then you discuss the option. That was good. You just have to enumerate the options, because never you have got enough time to explain the options. You just have to speak 3 lines and you have to touch that domain. So try to speak language from the patient information leaflet. I took my words from the patient information leaflets and just wrote them on the register. The first option you always have to give to a patient is, for miscarriages, letting nature take its course. You, whenever a patient comes with miscarriage, you first line you should be letting nature take its course. Okay, you can speak this knowledge. But if the patient is having a proper pregnancy and you have to induce it, then definitely this could not be spoken, but it is one of the option. Afterwards, you discussed with her that we can give you medical and surgical. That was quite good. So when she asked you that what you think would be better for me, you tried to handle it quite well, but the better answer would be, look, Catherine, I understand the concerns you have and I understand the anxiety you have regarding this pregnancy, but we are here to guide you with the choices. You both have the choices you have got. Both are evidence-based choices. We are here to guide you with choices, but the final decision, whatever you and your partner will choose, we will go with that. Also, if you are finding any difficulties, I can connect you to my consultant and you can attend with your partner and you can make your decision. So what you can think about it. So try to speak like this. Try to act better. You just have to act. The perfect actor wins the race. Okay. So that was explanation was good. One very important point was missing. Patient safety went borderline because of that. Long acting reversible contraception was missing. The patient has come with unplanned pregnancy, unwanted pregnancy. Now she will be done with the miscarriage within a week or two. But you have to tell her that we will be arranging an appointment with you for the long acting reversible contraceptive methods, so that you don't end up again in unwanted, unplanned pregnancies. Are you with me, Dr. Amara?
Yes, Dr. Sana.
So patient safety went borderline from that point, because already a patient has been coming with unplanned pregnancy and you haven't arranged an appointment for long acting reversible contraceptive method, then you can't pass the patient safety domain. So you could have just in the last few moments you could have told that I'm also going to connect you to my consultant and we'll arrange an appointment so that we can discuss some long acting reversible methods for you after we are over with this pregnancy, so that you don't end up again in unwanted pregnancy. That was missing. And one thing I would like to tell to all students that early pregnancy care module is a module where you can't miss red flag signs. You cannot miss red flag signs and you cannot miss early pregnancy assessment unit, or like whether the patient has come to recurrent miscarriage clinic or early pregnancy assessment unit. So red flag signs are must for early pregnancy module. They are a patient safety point. You always have to speak if you feel any spotting, if you feel any lower abdominal pain, because you are not sure that it is not ectopic, or you are not sure because although she has got one ultrasound, because you are not sure up till now. So you always have to say, if you feel any dizzy spell, if you feel any fainting episode, if you feel any lower tummy pain, or if you feel the bleeding is getting heavier, please report to us immediately. I will also be providing you with the 24/7 contact number of early pregnancy assessment unit. Thank you for your time and I will connect you to the counselor. So this is how you are going to end your station. Am I clear so far, Dr. Amara?
Yes.
Okay, so for me, your report card says that information gathering went borderline, communication went borderline, communication with colleague was past domain, applied clinical knowledge past domain, and patient safety, for me, I'm sorry to say, it's a fail domain. So you have got two borderline, one fail, and two are past domains. So it's a good start as we have 4 months ahead. For me, it's a good start for a station, and we hope to hear some better presentations from you next time. So, but it was a very good attempt overall, based on the first station and first module. Okay. So
Oh,
keep studying hard, and good news will come your way. Dr. Nazish will love to give you feedback. Over to you, Dr. Nazish.
Hello, Dr. Amara. It was really good to hear you after a long time.
okay.
Okay, so it was a really good presentation, and you have covered most of the points. Dr. Sana has already told you about all the important points that I had written on my register as well. So there is nothing much to add, but there is one thing, like there are just a few things. One thing I loved about your presentation was that you were safe about the patient in the terms that you were connecting her with the consultant. So it is very important when it comes with communication with colleagues. Then there are a few things. In some stations, there is a need for multidisciplinary team in which you have to involve all the relevant specialities. Like in this case, you can involve your consultant, like you already did, which was very good. Then you can involve the radiologist, which you can say imaging doctor, and you can involve the specialist nurse as well. But the consultant's involvement was really good because in this way you are somewhat patient safe as well. There is one thing
Mhm.
that I would like to tell Kim, and I would like to tell you as well, that it is a very good way that after 2-3 sentences, like Dr. Sana already told, you should check the patient's understanding. Or sometimes you can simply keep asking about the concerns, because it's not that the patient will tell you all the concerns in a spontaneous way. Sometimes you have to dig it out. Like once you asked, okay, the patient told you one concern, then you went with your flow, the patient didn't ask all the other concerns that were written on her notepad. And if all the concerns that are by the role player are not addressed, then the domain of the patient communication goes borderline. So you have to keep checking with the patient, like every 1 minute or every 2 minutes after you speak of certain lines, you can ask the patient, okay, so are you with me? Or sometimes you can even check that, okay, so am I clear so far? Do you have any concerns up till now? Am I clear so far? So these sentences are very good in communication because they add to your communication. This is one thing. Then whenever there is a station in which the role player is upset, you can always offer a counselor. There is no harm about that. Like in the previous molar pregnancy, when we can offer a counselor, in this station you have to assess about the patient. You can check that whether the patient is upset or whether the patient is okay or happy with the news. If she is happy with the news, then there is no need for the counselor. But if you feel like she is upset with the news, then you can connect her to the counselor. So you can say, okay, so at the end of my consultation, I can connect you to the counselor as well. So this simple line can be added as well, because this really gives a good impression. And then there is one thing that you can use visual aid as well. You can draw a womb, you can draw a copper coil and a gestational sac, a gestational sac, and you can tell the patient, see, this is the womb, and here we have the pregnancy, and here the copper coil is there. Then, as Dr. Sana told, you have to tell about the failure rates. Okay, so one other thing that I also noticed, Dr. Sana already pointed it out, was the long-acting reversible contraception. You definitely have to go about it, because this is the patient safety point in this station. This cannot be missed at all. So there are different like failure rates of different methods that I'm going to tell you. So if anyone wants to write it down, they can do that. First of all, we have the copper coil. It has a failure rate of 20 over 1,000 pregnancies in 5 years. Okay. First one is the
Okay.
copper coil, which has less than 20 over 1,000 pregnancies over 5 years. So you can say, so with the copper coil, every 20 in 1,000 patients may get pregnant. In case of the call Myrina, it is less than 10 over 1,000 over 5 years. In case of Implanon, it is less than 1 in 1,000 over 3 years. And if we go for sterilization, then it is 1 in 200. So these are certain failure rates that you can quote at different places. If any pregnancy failure comes, like, also it is very important to rule out that there is no domestic violence, as Dr. Sana has already highlighted, and it is not a forced pregnancy. And how are the relations between the couple, because this is also important thing in this. So Dr. Sana has already covered maximum points that should be added. One thing I noticed was that somewhere in between, you said this thing, okay, so we will help you get rid of it. So this term, I found it a bit offensive. Like, I think the patient should be told in a very mild language. Even if the patient wants to get rid of it, I don't think so. We should be saying to get rid of it. We should be saying it, okay, if you want to terminate it, we are going to respect your decision for that. What do you think, Dr. Mara? Isn't it a better line?
Yes, Navish.
Okay, okay. So this is all about the feedback. Dr. Sana has already pointed out the maximum things. So this is all from me. Overall, it was really good listening to you, and I really wish you to. I really wish to listen more from you, inshallah, in the future. Over to you, Dr. Sana.
Okay, so one important thing that I want to tell to all the participants and the candidates, the question that I asked Dr. Mara, that will it affect my chances of getting pregnant again, or will it affect my pregnancy? This was the role play concern in my exam, and it has got a very beautiful answer from one of the patient information leaflets, and it says that having a miscarriage or doing going for a miscarriage will not affect your chances of getting pregnant again or ectopic pregnancy. However, it will increase your chances of having preterm birth. So these are the two lines. If you want to all want to write, you can write it. This was the answer.
Okay.
Okay. So should I repeat it? I'll repeat it once. Going for a miscarriage or having a miscarriage will not increase your chances of ectopic pregnancy or decrease your chances of getting pregnant. However, it can increase your chances of having preterm birth the next time you get pregnant. Okay, so moving on to the
Okay.
next station. Okay, so Dr. Fozia, are you there? Hello?
Hi Sana, Assalamu alaikum. Yes, I'm here.
Okay, walaikum assalam. Dr. Fozia, you know that drill 2 minutes will be given to read the station, and then 10 minutes will be given to you to present the station. And after 10 minutes, I will tell you that time is over, and then the feedback will be given. So your time starts now. These are the domains you will be assessed for, and here you go.
Mm-hmm. Any other slide? Any other slide?
You can start now.
Hello, my name is Fozia, one of the registrars in the clinic today. May I confirm your name and age, please?
Hello, doctor. I'm Kai Ming and I'm 28 years of age.
And how would you like me to address you?
Kai is fine.
Nice meeting you, Kai. Kai, may I know from where you are and do you have any difficulty in understanding English?
I'm from China and now I'm comfortable with the English language because I've been here for a year now.
Oh, thank you very much. Because if you have any difficulty, you can let me know and I can arrange an interpreter for a better communication and for today's consultation.
Okay, sure, doctor.
Thank you. Thank you. So, Kai, I came to know from your GP letter that you're here to discuss some concerns regarding your reports. Is that right?
Yes, doctor, that is right. Yes.
Okay. Kai, would you mind if I ask you a few more questions to know more about you in the details? I will try to address your concerns, and I will, at some point, if needed, I will involve my consultant in today's plan also, and I will give you the patient information leaflet and the end, and together we'll come to the mutually agreed and acceptable plan. Is that okay with you?
Yes, that would be fine, doctor.
Okay. Thank you, Kai. So Kai, would you mind just telling me why we are meeting today?
Yes, doctor. Basically, I'm pregnant. I'm 8 weeks pregnant, and the GP told me that because of some concerns, some reports were ordered for me
Yeah.
before the pregnancy, and
Mhm.
I had one of previous pregnancies didn't end well. So you have the reports, and that is why the GP asked me that I should go and discuss with you that how you are going to manage this pregnancy so I can have a baby, normal baby now, because I'm very much depressed because last
Mhm.
time my pregnancy didn't end well.
I'm really sorry to hear about your previous pregnancy. How are you doing now? Are you okay?
Yes, it was quite difficult for me, but
Mm.
now I'm fine. Yeah, because I'm
I,
happy because now I'm again having a pregnancy.
I understand that. I know that would be a difficult part on your side, and my team of doctors are here to support you and guide you in whatever way we can. Okay.
Okay, doctor.
Kai, would you mind telling me, is this a planned pregnancy?
Yes, it's a planned pregnancy. Yes, doctor.
Okay, and how many weeks are you in your pregnancy now?
I'm 8 weeks pregnant.
And are you taking any medications, folic acid, anything like that?
Yes, I'm taking folic acid.
Okay. Any bleeding, any spotting from you down below?
No. I'm fine, perfectly fine.
Nausea, vomiting?
A little bit of nausea, but I'm okay with it.
Okay. Any flu-like illness and the rash in these 8 weeks?
No.
Okay. And have you contacted with your midwife for this pregnancy?
Yes, I have been to the midwife once.
And have they done some bloods for you?
Yeah, they took some blood tests and I'm not aware of the reports.
Okay, that's fine. Kai, some of my questions may bring back the difficult memories back to you, but these are very important for today's consultation. Would you mind telling me what number of pregnancy this is?
This is my second pregnancy.
Okay, and can you please elaborate what happened in the first pregnancy? Because this is the first time we are meeting, so I
Yeah.
need to know the details of that.
Yeah, I understand, doctor. I know that that was a difficult time, but I can tell you. The pregnancy was going fine, and I was 30 weeks pregnant, and suddenly I got a little bit
Mm-hmm.
and a spotting, but I took some paracetamol and tried to avoid it, and then the bleeding got heavier and the pain also got heavier, and then I went to the hospital and they told me, they did some scan and they told me that the baby is no more alive, and I was quite shocked because everything was going fine. However, I did miss some of my appointments because I have come from China and I was living in a refugee camp. I couldn't
Mm-hmm.
be regular with my visits to my doctor, so I did miss some of the visits, and I want to avoid this time that I want to have a healthy baby. That is why I'm presenting a little bit earlier, and I want to be early regular in my visits. So they told me that the baby has died inside, and then they gave me some medication to start the pains, and then the baby was born, and then they did the postmortem, and the
Mm-hmm.
report is available with you. And yeah, that was, but they didn't tell me in detail that what was the cause. So I'm
Mm-hmm.
also here to discuss the reports that what was the cause in my last pregnancy that can be avoided this time.
I'm really sorry to hear about that. How was the recovery after that, and when it happened exactly?
Yeah, yes, it was 6 months back, and it was my recovery was fine. I was fine afterwards. However, I went to the psychiatrist 2 times because I was quite stressed, and counselor sessions were there. Otherwise, recovery was fine.
Mm-hmm. And how are you coping now, Kay?
Now I'm fine. Previously, used to remain depressed, but now I'm fine. Since I've come to know that I'm pregnant again, now I'm fine, and I really hope that I get the best pregnancy outcome this time, and I have a baby this time. So I'm
Sure,
here that whatever you can do, just save this baby.
sure, we will try to give you the best management plan. At any point, if you feel depressed and you feel some support, you can tell me, and I can arrange the mental health team for you also. Is that okay?
Okay. Yeah. Thank you for that.
Okay. Coming to the next questions, have they arranged some blood test after 3 months after the pregnancy also for you?
No, no test was done for the after 3 months.
Okay, that's fine. And is there any other medical problem for which you are visiting your GP regularly?
No, doctor.
Any surgeries in the tummy or the down below in the past?
No, doctor.
Any family history of the concerns, clot formation in the legs and the lungs, any bleeding disorder in the family?
No, nothing like that, doctor.
Okay. And coming to your personal habits, do you smoke? Okay.
Uh, no, I don't smoke, doctor.
Any use of alcohol?
Occasionally.
Okay. And what do you mean by occasionally?
At weekends?
Okay, that's fine. That's fine. That's fine. And any use of recreational drugs? Pardon to ask me if you have.
Yes, I used recreational drugs for the last year, but now I've stopped them.
Would you mind telling me what was exactly the type that were you using?
Yes, I was using cocaine, doctor.
Okay. And you were using in the pregnancy also?
Yes, unfortunately, I was using it for the first 3 to 4 months of pregnancy, but then I
Mhm.
stopped it.
Okay, okay, that's fine. I really appreciate that you stopped during the pregnancy. And you are not using it now, is it so?
Yes, I have stopped it. Yes,
Okay. And what's your weight to height ratio?
it's 23.
What's your blood group?
It's O positive.
And do you have any allergies to any medication or anything like that?
No, I'm not allergic.
Thank you for giving me all this information. Is there anything else that you want to add that I'm missing?
No, I think that's all, doctor.
Okay. Okay. Would you mind if I examine you in the presence of the chaperone just to check your normal body checks?
Yeah, that would be fine.
Okay. So, okay, I have your reports with me. I have your postmortem report of the baby. I confirm your name and NHS number. Do you need someone to come and accompany with you at this time? Are you okay?
Why, doctor? Is there something serious? Because I've come alone.
Oh, the thing is that, Kay, some of the news might sound difficult to you, but I can ask my nurse to come and be with you as a support, so we can discuss the further management plan with you.
Okay. Yeah, that would be fine, doctor.
Okay. So, regarding the reports, as you told me that you're 8 weeks pregnant and your urine pregnancy test is positive. At this time, the pregnancy sounds going fine. Everything looks fine. It's a very promising thing. In your reports that was done earlier, they did not find any infection in your body, and they did some tests for your thyroid also. They were also normal. That's quite a good thing, and your urine was perfectly fine. But there was some concern regarding your one of the blood test and one from the placental examination of the baby also. Shall I
Okay.
go with that?
Yes, yes, please, doctor.
Reg-
Yes, I'm there to know the cause and detailed reports.
Yeah, I understand that. I understand your concern. Regarding the blood test, they found some unusual proteins in your body. This is called the sticky blood syndrome. Have you heard of that?
No,
Okay.
never.
What happened in this disease is that when these proteins come back as a positive, so it means your blood has a tendency to make the blood clots whenever there is a chance arises. This is called the antiphospholipid syndrome.
Okay.
But according to the protocol, we need to confirm these proteins again after the pregnancy in the 3 months times. And you're telling me you were not offered any test in the 3 months time again. Is it so?
Yes, doctor. Yes.
So, according to the protocol, if it's not being tested, so the test is not that much valid. So, I need to discuss this thing with my consultant, with your permission. That what we need to do now, because in the pregnancy, the validity of this test is not that much accurate as in the non-pregnant patient.
Okay.
Are you
So,
getting? Okay?
okay, so doctor, these are this sticky this sticky blood syndrome caused the death of my baby.
Okay, I understand your concerns and anxiety is totally understandable. So that could be the one of the cause. The second cause, I'm really sorry to tell you that you were using the cocaine. According to the researchers, the cocaine is to be the one of the cause that causes your afterbirth to get separated prematurely from your womb and cause the abruption and the bleeding that you were having at that time. Do you understand me?
So, doctor, I have killed my baby because I was using cocaine. I
Okay.
was thinking of it that I killed my baby. I knew it that because of cocaine I killed my baby. I don't know what to do.
Okay, listen to me, Kay. Don't blame yourself. It's because you told me that that's a very good thing that you stop the cocaine in the 3 months of the pregnancy. That is a very good and promising thing. But according to the researches, we are facing that cocaine may have long lasting effects that can affect your baby's growth and the placental growth also.
So, doctor, was cocaine the cause of baby's death? Please tell me.
Okay, at the moment, it looks like that according to the history and the things you are telling me, it could be one of the cause, and the proteins that are increased in your body could be one of the cause. But we haven't confirmed the protein, so I can't say exactly that would be the one of the cause.
Okay, doctor.
The reassuring thing is that that you have stopped the cocaine. So one of the factors that was the cause, it has been stopped now. So it would not be a further risk factor in your case. So hopefully we'll be having a future next this pregnancy healthy and the healthy baby as well.
Okay, doctor. Yes. Please do anything to save this baby because I'm quite worried. I'm quite upset because
Yeah.
I think that I could have killed my baby.
No, don't blame yourself because this will causing an extra stress in this pregnancy and that will harm your baby. Your baby's growth can be affected. Just try to eat healthy diet and avoiding any stresses and continue the folic acid. I will discuss with my consultants and I will book an appointment again in the week's times with you so we can make sure that whether we need to start you with some blood thinning injections, that is a treatment for this antiphospholipid syndrome.
Okay, so you will be giving me the injections?
Okay, not at the moment because we haven't tested the proteins again in the 3 weeks times for the confirmation of this syndrome in your body. So that's why I need a expert opinion from my consultant, and we will discuss with the blood specialist doctor also. If they think so, then we need to start you with the blood thinning injections.
Okay, doctor. Okay.
Okay. And give you some information leaflets about these cocaine abuse and the antiphospholipid syndrome also. I will write back to your GP about the plan, and I will see you again in the 1 week's times. At any time, if you have the tummy pain, if you have the bleeding and you're not feeling well, you're more than welcome to come back, and I will give you the 24/7 emergency contact number. Is that okay with you?
Yeah, yeah. Okay, that would be fine.
Thank you very much. Anything else that you want to ask?
No, I'm clear, doctor.
Thank you very much.
Thank you. Okay. Very well done, Dr. Fozia. It was a quite good attempt, and I am quite impressed that you tackled, because most of the candidates, 90% of the candidates are unable to reach to cocaine, and they manage the antiphospholipid syndrome and they carry the station and they get the station failed. But it is very appreciative that you picked the cocaine, and that is the gist of the station. But there are some things that I need you to improve, and I'll just go it one by one on domains. The most important thing I would like to tell you, and I want you to improve, is timing.
Don't
Time.
say that and again. You know, my exam, I know that that was my major problem. In my exam, to be
Yeah.
finish my stations at 9 minutes and 30 seconds. I promise you for that.
Okay. So because our time was a little bit 1 to 2 minutes above the limit that I was set for you. Okay. So coming to the information gathering, your introduction was very good. Agenda was excellent. Information gathering, a little bit things were missing. If you got the report for large retroplacental hematoma, it is
Mhm.
important to rule out other causes of abruption as well, because you are not sure that cocaine is causing the abruption. It could have
Okay.
been a trauma, it could have been a fall. It could have been a domestic abuse. Based on she was Chinese, she was living in refugee camp. These patients are quite prone to domestic abuse and violence and sexual assault. So it
Okay.
is very important. You are not 100% sure that the hematoma was because of cocaine. Cocaine is one of the cause, and the 80% chance that cocaine was the cause, but 20% causes you have to rule out. So what are the causes of retroplacental hematoma or abruption? You have to rule out raised blood pressure. You have to
Mm-hmm.
rule out trauma. You have to rule out fall. So you have to rule out any raised blood pressure with proteins in urine. In the last time you were told about that. So these were important things that you have to rule out. And one very important thing that in your previous pregnancy, was your partner supportive of your pregnancy? Do you consider yourself to be a happy couple? Because sometimes
Oh,
uh,
I
uh,
missed that.
yeah, the
Mm.
Royal College, what they do, that they just give these type of investigations to divert your attention, and you don't go to the gist of the station. However, in this station, the gist was cocaine abuse, but sometimes they can change it. They can give the cocaine abuser, they can give the APLS, and also they can give the violence as well. Because it has happened in my exam station that there were three scenarios, and you have to just reach to the gist of the station. So always ask, because in refugee camps living patients, always you have to rule out the domestic abuse or the violence or sexual assault is very common in these patients.
Okay.
Okay,
Mm-hmm.
so
Sure.
this because of these three very important points, information gathering, I would say, went borderline, because if you are not ruling out causes of abruption, you can't manage the patient this time. Okay. So
Okay.
this is important. Information gathering, alcohol. She said she is drinking alcohol occasionally. In pregnancy, no amount of alcohol can be justified. No amount. You
Oh.
have to stop. In gynae that was fine. If it was a gynae station and you told her, okay, that's fine, that wouldn't be fine. But in obs patient, no amount of alcohol is acceptable, and if you don't connect her to the stop alcohol services, patient safety went borderline.
Mm-hmm.
Am I
Okay.
clear so far?
Yes, you are.
Fetal alcohol syndrome is very common. No amount of alcohol can be justified, and from here, your patient safety, your whole of the station was very well, but this point, this went borderline because of alcohol cessation services. Then you asked her that when she stopped cocaine and when she stopped, that was very good. You probed that. But one important thing you have to say that I know that living in refugee camps and living in could be a little bit difficult, and stopping recreational drugs, it can have a little bit stressful impact. So how are you finding it? Are you finding difficult to stop recreational drugs, or are you okay with it? Because I know some sport groups, I can just attach you with them and you will find it easier to carry on with your journey of quitting the recreational drugs. So this sentence you can speak to just show the examiner that you are also addressing that she has left cocaine, but she can come back to cocaine. She can come back to cocaine anytime. provided that she is living in the refugee camp. So
Okay.
this thing was missing. Otherwise, information gathering, everything was covered. So communication, gathering went borderline, but communication with patient, that was a complete pass domain. Communication was very good. You were empathetic. You were checking her understanding. You were taking her along, and try to incorporate these sentences. Do you want me to repeat anything? Or Kai, any questions so far? So I can proceed further. Try to incorporate these two sentences because these are very important. This shows that you are taking a person, a layman, along with you. You are telling her, are you with me, and do you want me to repeat anything so that I can proceed further, so that she can absorb the previous information and you can then just move further. But communication was a past domain. Then communication
Okay.
with colleague, that was a past domain. You involved the consultant, that was very important. You involved the hematologist, that was very good. uh, Counselors, you can also have talked about the counselors at the end of the station as well, that coping with the situation. I can just connect counselors. You have to speak in every station, because Royal College, they want to hear about counselors, because many of these stations, they give patients who are having struggling with some past trauma or present trauma. So counselors are very important, but this domain was a past domain.
So,
Applied.
Sana, perinatal mental health team covered the same thing, no? This is the same. They covering the same part. Counselors.
Okay, yeah, that's fine. But you can also, at some point, you can mention a counselor as well. So to just,
Okay.
yeah, perinatal mental health team is a good option, but for the examiner, because sometimes in the examiner key, they have written counselor and start that point. So just to get that point and just to register the examiner that you are focusing on her psychological health as well, because speaking therapy is very important. So just you can just incorporate once. Otherwise,
Okay.
communication with a colleague was a past domain. The next domain we have got patient safety. Patient safety was going a past domain just because of alcohol. It went borderline. Otherwise, it was a past domain. Okay.
Mhm.
Okay, and one more important thing you could have add that are you still living in the refugee camps? Do you want some kind of support or anything that you think that is having bad impact on you, on your pregnancy? So I can connect to the support groups, or are you finding it fine in the refugee camp? Because we have got some support groups, we have got some organizations that can help you because you are pregnant, to have a better pregnancy outcome and for your better health as well. So these sentences, a better actor will always win the game, because these sentences will show that how empathetic you are and how you are feeling for the patient, and you are aware all of her circumstances. So try to speak these sentences. Otherwise, patient safety was, it's a borderline domain, and applied clinical knowledge is a full on pass domain, because you reached to the gist of the station. And I loved your answer when I asked you when I was crying, because this was the same scenario in my exam. She started crying. She asked me, I you mean I killed my baby? So you answered very well. You told her that I respect your anxiety, and it is quite understandable. Cocaine could be one of the causes, but we are not sure at the moment that what caused the death of your baby and what caused that unfortunate event. However, what the history you have provided me, what seems most likely that cocaine could be a cause, and there could be some other causes as well. We are just going to investigate you to reach to the cause, and we are going to provide you the care to have the better, best pregnancy outcome. And in this journey, and in this my consultant and other team of doctors will be involved, so that we can find the what was the main cause. So that was a very good answer, because you always have to give a diplomatic answer when the patient says, did I kill my baby? You have to say that it was one of the causes, but it could be the cause, but there are many other causes we have to investigate so that we can reach to the cause. So applied clinical knowledge was a full on pass domain, and uh, everything else you covered in applied clinical knowledge. So for me, two domains are borderline, information gathering and patient safety, and three are pass domains. And overall, it is a pass station. Just try to manage your timing, and it was a very good attempt. Keep it up. Dr. Nazish will give you the feedback. Dr. Nazish, over to you.
Hello, Dr. Fozia. How are you doing?
I'm good, Alhamdulillah.
Okay, it was really good to listen to you.
And it's a very, I would say, the very tingling sensation that I'm going to listen from you for my feedback.
I think Dr. Sana has already covered. I'm mostly writing down
I,
all the
I,
points on my register, and I'm
uh,
taking down when Dr. Sana speaks any of it in the correction. So almost all are done. So, but there are a few that I have noticed. Just one or two you can say.
mhm,
But let me tell you about them, and then I will share the exam experience because this was one of the station of the exam as well. So, one thing is that I was really very happy when you said the interpreter, which shows that you are definitely a very strong candidate, and the communication. I'm always a fan of your communication. So, one thing was that you offered the interpreter, realizing that the name was Kaming. As Dr. Sana has already told that whenever there is an immigrant, we have to many things come in our mind, and we always offer one interpreter to that patient. Then we have to rule out the sexual abuse, the domestic violence, and the
mhm,
drug abuse. These 4 points have to be covered in every immigrant. Like if you see the name Shazia, if you see the name Kaming, I think one of the exam candidates was like Saima Akhtar in our exam, and there were many such some Chinese names were there, some Pakistani Indian names were there. So these all show that these are immigrants. So this
mhm,
famous scenario comes, and most of the times it is attempted as an antiphospholipid syndrome, but you cannot attempt this as an antiphospholipid syndrome because only one report is not conclusive of antiphospholipid anti and syndrome. So you cannot take it that way. So it was really good that you picked it and you went in the way of cocaine abuse, and this station was passing in that aspect. One thing is that in the same station, sometimes they give that the patient also has vaginal candidiasis. So when vaginal candidiasis is given, what will you think about that? Like, what will you be coming in your mind?
For vaginal, it could be the vaginal candidiasis. There is a decreased immunity. For the decreased immunity, could be the pregnancy, could be the one of the cause, and then there is a other drug abuse also. So we need to follow these things, and then by investigating it further, swab taking and providing her the proper treatment. And the vaginal candidiasis, no, it's not a cause that cause her to the preterm labor. Mhm.
You are very close, Dr. Fozia, because vaginal candidiasis, when given in an immigrant patient, you will immediately think about the drug abuse or HIV. Because
Yeah.
when there is drug abuse, the patient is having HIV infection, and that makes the system like compromised, that makes the immunity compromised, and the person can get vaginal candidiasis. So, along with this famous scenario, it is very common that in exam it comes that the patient is having vaginal candidiasis. So all of these things lead to the thing that she is an immigrant. That's why they are trying to give you some hint about some drug abuse, about some sexual abuse, or these things have to be ruled out for sure. Then the exam scenario that came in our exam, one of the exam scenario was that the patient was having a previous IUD baby and the cause was abruption. And as Dr. Sana told, the role player was literally crying and she was like, I don't want to affect my next baby. So what are my options? So the scenario was exactly like that. But when I asked the role player, okay, so do you take any recreational drugs? And she was like, yes, I used in the past. Means she was not, it is not very easy to get it from the patient that she was having cocaine abuse, because the
Yeah.
role player may say, okay, yes, I was having some drug abuse, and they simply don't say cocaine abuse because this is the gist of this station. So then you have to ask the next question, okay, so were you using cocaine? So then the role player told me this, yes, I was using cocaine. So this was the whole gist of this station, the provision of a counselor or the perinatal mental health team. Counselor is an easy word for the patient, so it is a very it is a good choice. So when you pick the cocaine, the station is passed there and then. The other domains like communication with the patient, it was definitely a very strong domain of you, as already you are really good with the communication. So one thing I noticed was that in the start you said, okay, so from your GP letter I can see that. So it was not a GP letter given. Am I right?
Yes, you are. I spoke in a very fancy.
Okay. So at the end, you can say, I can write back to your GP because GP follows all the patients. But in the
Right.
start, because it was not a GP letter, so you cannot say, I can see from your GP letter. You can generally say, okay, I can see that you have come with this problem. So
Yeah.
this was
Okay.
one thing that I noticed. And then at a few points, you said placenta, which is a medical term. So after
Mm.
birth is a better way to say that. Other than that, all of the things are already covered by Dr. Sana, and it was really, really a very strong presentation as always. And the time was slightly over, but I think the time is manageable for you.
Yeah, I tried to work on my time management last time also, but in the exam, I noticed and I realized that time was not a problem for me. So I'm not taking more anxiety of the time management this time. I work
Okay,
on
yeah.
Yes,
it.
that's also right. Yeah, that's good.
Yeah, because
Okay,
I
so that was all.
are in the
Yes.
exam scenarios, and when you're sitting for the exam station in a real exam, you know that where you are grasping and where you are lacking. So this is the thing I found in my exam. So this time I'm not taking a stress of the time. I will work on other domains.
Oh,
Yes, that's also right. Most of your domains are passing. Just there are a few things that Dr. Sana has already highlighted a bit as well. One thing that you could have added, but it is not a very compulsory thing, but you could have added because you know that according to the guideline, the cocaine is one of the major risk factors of causing an SGA baby. So somewhere you can mention a slight thing that okay, so from 26th week onwards or from the third part of the pregnancy, we will be doing some serial ultrasound scans for you. So because the Doppler ultrasound is indicated in all the cases of cocaine abuse, or because the patient was having the past history, so you skipped it, it was right. But if the patient is the current abuser, then we can add that as well. So these were the points from me, and it was really a good presentation, and I wish you all the very best for the exam.
okay. So
Thank
one thing I would like to add that whenever there is a small, sometimes they give an advanced pregnancy. So then you have to speak about the Doppler and you have to speak about the ultrasound because this was a role play concern in the exam scenario that how will you monitor that my baby is not small this time. So you have to tell about the Doppler and the ultrasound scans because if you go to the small for gestational age guidelines, there is written that cocaine abuse is a major risk factor. And if SGA baby has been caused by cocaine abuse, then you have to do Doppler from 28 weeks onwards. So you can add if the patient comes with an advanced pregnancy. And one thing most important, I would like to tell to all the participants and students that these kind of stations, they are very difficult to make the role players speak because they don't go towards the cocaine abuse. They try to just deviate you towards other scenarios because this is the guidelines from the college that if they go in the direction of APLS, then take them towards them. If they go towards the direction of cocaine, you have to take them towards that direction. So if you feel at any point that this is some foreigner, this is living in refugee camp, or there is something fishy with this report because only one report is given, there is some hidden agenda. Always make the role player to speak because many students on our day they didn't reach to the cocaine and the whole of the station was just fail. So this is the gist of the station. And cocaine, I want all of you to write that cocaine causes two things: small for dates and retroplacental hematoma. Cocaine is the cause of these two things, and you have to just write it and cram it up that cocaine is one of the cause of abruption as well as small for gestational age baby. But you always have to rule out other causes of abruption as well. You cannot skip that. You can never be 100% sure of anything. So this and now thank you, Dr. Fozia. And now the next station would be,
thank you so much, Sana.
yeah, who is the next participant? Okay, so Dr. Sadia, do you want to present the next station? Hello, Dr. Sadia, are you there? I guess she's not listening to me. Dr. Nazish, can you please contact Dr. Sadia? Can you message her if she wants to present? Okay, so we have got the next station. Dr. Amna, I guess, hasn't been back from her operation theater. Kim, are you there?
Yeah. I'm here.
Okay. Do you want to present the next station because Dr. Amna hasn't come back from her surgery?
Okay, can.
Okay, you know the drill?
Mm.
You know the drill, and I'll just start the time for you. And here you go. Take your time. Take your 2
Okay.
minutes.
All right. Next, please. Any other page?
No, that's all.
Okay, that's all.
You can start now, Kim.
Okay. Hi, I'm Dr. Kim, one of the doctor today. May I confirm your name and age, please?
Yes, hello, doctor. I'm Linda Holiday. I'm 25 years of age.
Hi, Linda. Is it okay if I address you as Linda?
Yeah, that would be fine.
Okay. I can see that you are having some pain and vaginal spotting. Is that right?
Yes, doctor, that is right. I'm having severe pain on the right side and I'm unable to sit because of that pain.
Oh, I'm sorry to hear that, Linda. Do you need any medication or any painkiller before we start?
Yes, please. Yes, please. That would be very great of you.
All right. Do you have any allergies before I giving you any medication?
No. I don't have any allergy.
All right. I will let my staff to serve you the painkiller. Is it okay if I continue with the consultation today?
Yeah. I'm feeling a little bit better. You can continue.
All right. Okay, Linda, may I ask how is your pregnancy so far?
Yes, pregnancy is going fine and everything was okay. And when my pregnancy test came out to be positive, I started taking folic acid and some ultrasound was scheduled for me, but everything was fine. But uh, now I'm having this severe pain since morning on right side and also 2 to 3 spots I have observed on my pad.
All right, Linda. Do you know how many weeks in your pregnancy now?
Yes, I'm 7 weeks.
All right. May I ask you a few more questions? Do you feel any fainting episode currently?
Uh, no, nothing like that, doctor. Just the severe pain and the
All right.
spotting.
Okay. Any pain at the tip of your shoulder?
No, doctor.
Okay. Do you know about your blood group, Linda?
Yes, it's A negative.
Do you happen to know your partner blood group then?
Yes, it's B positive.
All right. Any reservation for blood transfusion?
Uh, no, doctor.
All right. May I ask, Linda, do you smoke?
No, I don't do that.
Okay. Do you have any previous surgery to your tummy or pelvic region?
Yes, I have previously, 1.5 year back, I had a surgery on my lower tummy because I had ectopic pregnancy of left side. So they did the surgery and they removed my left tube.
I'm sorry to hear that, Linda. How do you coping after the surgery?
Yes, I'm fine now, but that was quite a stressful time for me, and I was very much stressed about afterwards. But now I'm happy that finally I'm having a pregnancy, so I'm okay now.
Okay. Uh, Based on the previous surgery, do they ever say that you have any infection in your pelvic region?
No, nothing like that.
Any chance you have a sexually transmitted disease?
No, doctor.
All right, Linda. Thank you for the information. May I ask, what is your body height ratio?
Yes, it's 27.
Okay. Thank you for your information shared, Linda. Do you have anything you want to add?
No, I think that's all, doctor.
Okay, Linda. A bit about your habit. Do you take any alcohol?
Sorry, doctor, I didn't get you.
Do you drink? Do you take alcohol or take any recreational drugs?
No, I don't do that.
Okay. How is your partner? Is the support at home is good?
Yes, the sport is quite good. My partner, we both are very happy, and he's quite sportive.
Okay, Linda. Thank you. Do you mind if I have your I do some examination with your consent with a presence of chaperone?
Yeah, okay, that would be fine.
I'm sorry, Linda, I might not have a good news for you today because based on the report that I received, confirmed by your name and your HHS number, it seems that we are dealing with a condition we call ectopic pregnancy.
Okay,
Do you
what is
follow
that?
me so far?
Yes, what are you saying, doctor? I had previous, again, I'm having the same condition. That is not possible. Please check the report again. I have already have one ectopic. I can't have another.
Based on the report from the ultrasound, Linda, it seems that there is that the pregnancy is not appear in your womb, unfortunately, and it seems that the pregnancy is happens outside of your womb. It's confirmed by the scan, and based on the level of your pregnancy hormone, it also considered a bit high. Hence,
Please
unfortunately,
report
this
the, please repeat it. Please, doctor, please repeat that report. I can't believe that I can have another ectopic. There is some mistake. Could you please repeat the report for me?
I know it will be very stressful for you and your family currently, Linda. I'm sorry to tell you that the only ways that I can have a confirmation, I might need to admit you and bring you to surgery because of your symptoms. You're having pain and you're having bleeding. And it seems that the scan finding shows that you have the ectopic possibly at the same site of your previous ectopic, which is have a higher chance of it reoccur based on the previous history that you had from the ectopic. And I make myself clear, Linda.
Okay, but doctor, previously they told me that they have removed my tube. Then in the same tube, I am having again pregnancy.
Based on the scan, that it seems that you're having the left tuber pregnancy based on the scan, but your presentation seems to be on the right. So at this moment, I cannot 100% tell you which side of the uh, ectopic pregnancy it's occur. So for the best confirmation, I might need to bring you to the operation theater so that we can do the keyhole surgery to look upon where is the pregnancy occur. And by chance, it will depend on what we see in the operation theater. Either we can salvage your tube for your better pregnancy outcome in the future, or if there is already damaged the tube, then we might need to remove the tube for the sake of saving your life and also prevent it from further bleeding. Am I make myself clear, Linda?
Doctor, can you please give me some medicine? I don't want to have another surgery. Just give me some medicine and I can get I was very much previously I'm having one surgery. I don't want to have another surgery.
I can understand, Linda. I am very sorry because of uh, it shows in the scan finding there is a few option for the management of your condition. However, with the presence of the fetal heart activity in the scan, I'm afraid that the medication might not be much help in terms of the condition because the medication itself have a risk and side effect. And if there is a presence of the fetal heart activity, I'm afraid it might not work and you might need to be undergone the surgery again. So I might not want to risk you for the two possible risk and complication. Hence, I'm sorry to say that the best option might be the surgery. I will
Okay, so doctor, you
get
will not remove the tube, right? You will not remove my tube because I have one tube only, and if the pregnancy comes out to be in that tube, you cannot remove my tube, right?
The about the removing of your tube, there is a two option, Linda. For now, I will try to have a tube to be salvaged. Mean I will try to keep the tube. However, if there is evidence that the tube is already damaged, then I might need to take the difficult decision to be removing the tube together because by keeping the tube that already damaged, you might have the risk of getting the ectopic pregnancy again. And of course, I will gather my consultant together to assess about the tube. That is a possibility. If the tube is fine, then we might just remove the pregnancy tissue from there and we try to keep your tube as much as we can. Am I
Okay.
clear, Linda?
Okay, yes, I'm getting it. And if you don't remove my tube, so how will be sure if you will be sure that I don't need any further treatment?
If we're able to save your tube in this current pregnancy, then I will have you to follow up under our center with your pregnancy hormone. We're checking it every week until it become normal. And then
Okay.
after that, if the tube reading is normal, then we uh, consider that the pregnancy already end. And
Mm-hmm.
then we will follow up, give you another follow up to see whether everything is fine. If you have any abdominal pain or you have any bleeding, then you need to come back to us. I provide you the 24 hours early pregnancy assessment unit so that you can to us anytime you feel unwell. I also provide you with patient information leaflet so that you can understand you further and write back if you are follow up in your GP. Am I
Okay.
clear, Linda?
Yeah. And doctor, what are my chances of having future normal pregnancy? I really want a baby. What are my chances of having? Will the chances are normal that I will have a normal pregnancy again?
If we are able to salvage or we are able to keep the tube, then the chances of you having a next pregnancy will be 7 out of 10 will have a successful pregnancy.
Okay, and what are the chances that it will happen again?
The chances will be happen again. It will be slightly higher. Will if there is a 100 women having the same problem, maybe around 10 to 15 will have tendency to be recurrence ectopic.
Oh. Okay, okay. Thank you, doctor.
Okay, thank you, Linda.
Okay. Okay. Thank you, Kim. And I'll go first with the good points. It was a composed presentation, good presentation. You tried to cover the maximum points, but some of the very important points are being missed, and I'll go one by one. For in that first domain that I'm going to discuss is information gathering. The good points, you ruled out disease spells, you ruled out allergies before giving painkiller. That was an excellent point. That is a patient safe point. You got a tick on that. Pain in shoulder, you did it. The most of the candidates, they forget to ask the pain in shoulder, but you did that. That was a very good point. You ruled out disease spells. And a little bit, you could have asked her to elaborate on her bleeding. You could have, because sometimes the patient, they just casually say, but it's better to ask them to elaborate. And then when you ask them to elaborate, then they say, yes, I think I had one pad soaked yesterday as well, but that wasn't much. And from the morning, there is spotting and any clots or anything else you have observed in your bleeding. So it's better to make them speak, elaborate on the bleeding. So otherwise, history of present illness was complete. Coming to the next point. Okay, so when you asked about sexually shared infections, whenever you asking some personal question, it is better to just signpost before that. Are you getting me, Kim?
Yes, yes. Okay.
Okay, so you can just say, Linda, a few personal questions. That sentence is enough. Linda, a few personal questions. Do you mind me asking a few personal questions? Is it okay I ask you a few personal questions? Whatever sentence suits you, you can choose one, but try to speak one of the sentence. A few personal questions. Do you mind asking me a few personal questions? Is it okay I ask you a few personal questions? And then you can ask that by any chance, have you ever been treated for any sexually shared infections in the past? Okay, so don't you think this is a better sentence, Kim?
Yes. Yeah.
Okay. So whenever a patient is coming with repeated ectopic pregnancy, you can ask this question, any sexually shared infection in the past, or pardon me asking, any multiple sexual partners. So this is very important. Sometimes the multiple sexual partners, please mute your mic, everyone. Mute your mic. Okay, so these are two important questions because the patient is coming repeatedly with ectopic pregnancy. You cannot ignore multiple sexual partners. She might be having multiple sexual partners. So you have to rule out that. Okay, so
All right.
that was good that you asked previous pelvic surgeries or previous any surgery. That was very important point. Kim, can you enumerate for me the causes of ectopic pregnancy? Four causes. Tell me now in points. What are the four causes of pregnancy?
It can be due to tubal factor like endometriosis, pelvic inflammatory disease. It can be due if she have any history of ectopic pregnancy, or she
One more.
pregnancy with IUCD.
Okay. Anything else?
Uh,
IVF. IVF is a very
oh,
important cause, and smoking. Smoking is also
yeah.
an important cause. So these are some important causes of ectopic pregnancy. So you ruled out you ruled out sexually shared infections, but it is better to also rule out multiple sexual partners and sexually shared infections. And you ruled out previous surgeries. That was good. You also ruled out smoking. Okay, so if you could also ask about spontaneous conception, that would be a better option. What do you think?
Okay.
Okay.
Yeah.
So this was his information gathering. However, you missed a few points. Still, I will give you a passing domain. This was then a very important main point that you missed. That was review the notes of previous surgery. You did not review. I gave you the wrong information just to check that whether you will review my notes or not. Most of the patients, most of the role players will be giving you wrong information, will be giving you misguided information because she was in pain, she was casually talking, and she just told you that maybe it was a left side of topic pregnancy. So you there and then you have asked her, can I review your notes with your permission? So that was a
All right.
patient safe point. That was a patient safe point. You cannot skip that. Reviewing notes is a patient safe point. If you don't review notes, your patient safety domain goes borderline there and then. So
All right.
write it anywhere that whenever a surgery is there, you have to ask review notes. Another important thing, you have to ask whether it was a keyhole surgery or whether it was an open surgery. Why is it important? Because if you have to, whether it was a keyhole surgery or an open surgery, because maybe she's having some adhesions formed and that is causing her to have repeated ectopic pregnancies. So that is an also important point. However, you asked about recovery. How was your recovery? Any infections afterward? That was a very good point, because having infection after a surgery makes you prone to have further ectopic pregnancies. Okay, so this was about the information gathering. Never miss notes again, Kim. Okay.
Okay. All right.
Okay. Smoking was good. You asked sport. Okay. You ruled out allergies. You asked PMI. You asked about blood group. That was a very good point. Okay. Just answer my question. Does this patient need NTD?
Yes.
Okay. You have answered yourself. Okay. So don't forget it.
All right.
Whatever points I'm telling you, you have to go after this class, you have to make a note and you have to write with bold markers that I forgot these points in my presentation and I can never forget these points in my exam. Okay, Kim?
Okay, sure.
Okay. Communication with patient, your communication was fine. You are empathetic. You this time you tried to take the patient along with you. You also tried to check the understanding. Are you with me? Are you following me? And try to incorporate these sentences as well. Any questions so far? Okay. Or do you want me to repeat anything? Otherwise, communication was good. Uh, the next domain, you did the examination, that was good. You did the breaking bad news in an empathetic way, that you want someone to accompany you. Okay, so one thing you could have asked her, that one thing was missing in the communication, that do you want me to explain ectopic pregnancy or are you aware of the details that what it is? However, she was having an ectopic last time, but the chances are there that she is not aware what is ectopic pregnancy. So it is better to ask, because sometimes there is a mark in the examiner's key that whether the candidate has explained the condition in a layman language or not. Okay, so it is better to ask, do you want me to explain? And when she says okay, she will always say, please explain. She always 100% of the times role player will say, please explain. And then what you have to do, the first sentence that should come out from your mouth is, let me explain you with the help of a diagram. There and then you get a tick. Okay, all of the students write this point, let me explain you with the help of a diagram. You have to make a womb, you have to make a tubes, and you have to tell her, look, Linda, you see this is the womb, these are the tubes, and from here from the womb sperms travel, they travel all the way along up to the tubes, and in the tubes they meet up with the eggs and the pregnancy happens, which travels back to the womb and then implants there. But sometimes due to certain circumstances, due to previous surgeries, previous infections, or smoking or some other reasons, the pregnancy cannot travel back to the womb and it implants there and then. And when it implants in the tube, we call it as ectopic pregnancy or tubal pregnancy. If it keeps on growing over there, it will cause certain problems for you. The tube can get ruptured. You can have life-threatening bleeding. The bleeding can happen in your tummy and you can end up in emergency surgery as well. I'm afraid to tell you that, but we have to end the pregnancy here. We have to go for the treatment option, because this isn't going to stop on itself and it will keep on growing and cause problems for you. Okay, Kim. So
All right.
this is how you are going to explain to her. Okay, so the explanation was missing. Okay, now coming to the management, patient safety, one point was missing. So I will give you borderline because you didn't review the notes. Because sometimes some drastic events might have happened in her last surgery and you didn't review the notes. Some blood transfusions might have been given. She might have went to the intensive care unit. So you cannot skip those notes. So patient safety went borderline. Applied clinical knowledge, Kim, you have a good grip of knowledge. You know how to tackle the knowledge and you know where to hit. It's just get it a little bit organized. Are you getting me? Just try to,
Yes.
just I will give you one suggestion. Just try to first enumerate the options. You can say, uh, Linda, I can see you are anxious and you are a little bit worried. But based on the ultrasound report and the reports that have been provided to me, the fetal heart activity is there. and your pregnancy hormone level is also on the rise. We have got three options of treatment for a woman who presents with ectopic pregnancy. Either we can manage, let the nature take its course. We can give some injections called methotrexate to resolve the pregnancy. And the third is the surgical treatment option, in which we do the keyhole or open surgery. But I'm afraid to say that based on your report, surgery seems to be the suitable option for you because medical option won't work based on positive fetal cardiac activity and higher pregnancy hormone report. Are you with me, Linda? So this is how you first enumerate whether the patient is candidate for surgical or not. Always, always, always you have to enumerate all the management options. Only there and then you can get the full marks in the applied clinical knowledge. Okay, all the students, please note this point. Whatever the patient comes, please enumerate management options. The college wants to listen all the management options. They don't want to listen one management option. They want you to enumerate. So you just enumerate in 3 lines and you get full marks in applied clinical knowledge. Okay, so I'm afraid, Linda, that surgical option is a better option for you because you are having severe pain, and it will be surgery will be a better option to resolve this pregnancy issue. But in surgery, I will talk to my consultant, and my consultant would be here anytime to talk to you and discuss your concerns. We have two options for surgery. We can go through the keyhole route or we can go through the open surgery. During the surgery, the expert team of surgeons will have a look on your tube. If it seems feasible to remove the pregnancy tissue and save the tube, they will go with that based on your scenario that your previous tube has already been removed. But sometimes, Linda, unfortunately, the circumstances are as such that we cannot save the tube. Sometimes the tube is ruptured. Sometimes the tube is embedded in the adhesions. Sometimes there are other circumstances that we cannot save the tube. In that case, we have to remove the tube. We call it a salpingectomy. However, it is too early to tell you that which option the surgeons will go with, but they will consider the both options and they will choose what suits you the best. If they go for saving the tube, then we have to follow you up on weekly basis with pregnancy hormone test. And once it becomes negative, then you will not. Then it will show that the pregnancy has resolved. Okay, so this is how you are going to take the station. And there was one mistake, Kim. When I asked that what are my chances of having a successful pregnancy next time, there is a very beautiful answer in the patient information leaflet, and I want all of you to write that. And that's when the role player asks, "What are my chances of having successful pregnancy next time?" So you are going to say that chances of, if you have one tube after ectopic pregnancy, if you have one tube, your chances of getting pregnant and having a successful pregnancy outcome are quite good. However, having one tube can slightly reduce your chances of conception. So this is the line that you have to speak, and it is a very beautiful line from the patient information leaflet. And the other concern that I asked you, Kim, that what are my chances of having ectopic pregnancy again? So in general population, the chances of having ectopic pregnancy are less, but in the population that already have ectopic pregnancy, has history of repeated ectopic pregnancy, in that 7 out of 10 women can again have ectopic pregnancy. So this is learned from the pill, this percentage. Okay.
Okay.
Okay, otherwise it was good. So for me, information gathering is a past domain, communication with patient is a past domain, patient safety went, it was, sorry to say, but it was a failed domain because 2-3 points very important for missing: NTT and review notes. Applied clinical knowledge is a past domain, and communication with colleagues was a past domain. So overall, it was a past station, and it was a very good attempt. Try to organize yourself and try to incorporate the sentences that I have given to you and try to enumerate management options. Very well done, and keep it up.
All right. Thank you. Thank you.
Thank you. Okay, so Kim, it was Kim. Now see who we have got.
Okay, so we have Tabinda who has joined us. Tabinda, would you like to present the next one?
Yes, ma'am.
Okay, so Kim, there was one point that I didn't notice. Did you say that safe contraception option?
No.
Okay, so see, it is a case of ectopic pregnancy, so we need to give her some barriers and some safe contraception. This can be added as a point as well. Otherwise, all the other points have been addressed by Dr. Sana already, and the presentation was beautiful.
Okay, so
Okay,
we have
so we have Dr. Tabinda with us.
Okay, so Dr. Tavinder, the drill is I'll give you 2 minutes. The station will appear on your screen. I will ask you to start. You will have 2 minutes to study the station. And when I start you to
Okay.
start the station, you will be having 10 minutes to complete your presentation. After 10 minutes, I will stop you and then the feedback will be given by me and Dr. Nazish. So your time starts now and here you go, the station.
Next slide. Slide. Previous slide. And next slide. And next slide.
Okay, you can start now.
Yes, ma'am. Hi, I'm Dr. Tabinda, one of the doctors in the early pregnancy unit. May I know, can I confirm your name and age, please?
Yes, doctor. I'm Lily Savage and I'm 25 years of age.
How may I address you?
Lily is fine.
Okay, Lily, I have gathered from your notes that you are here in early pregnancy unit because you had vaginal discharge and your urine pregnancy test is positive.
Yes, doctor,
Is that
that is
right?
right. Yes, doctor, that is right. I did my urine pregnancy test 2 weeks back and it came out to be positive and I was very excited and everything was going fine. But since the morning I'm having this brown discharge and it made me a little bit anxious and the GP just referred me here and I don't know what has happening. Can you please explain why this discharge is there?
Sure, Lily, I will address your concern, but before that, I want to ask you a couple of questions. Then I will address your concern, and then we will make a safe management plan for you. How does it sound?
Okay, yeah, that sounds fine.
Okay, Lily, tell me about your this pregnancy. How's everything? When was your last menstrual period?
It was 8 weeks ago, and pregnancy is going fine up till now. I have been to the midwife once, and I've been taking folic acid, and everything else was going fine.
Mm-hmm. Is it your planned pregnancy?
Yes, yes, it is my planned pregnancy. Yes.
Okay. Have you ever noticed any bleeding?
No, just today this discharge.
Okay. Do you have any pain in your tummy?
No. No, pain is not there.
So any problem with water work?
No,
Okay. And shoulder tip pain?
no, nothing like that, doctor.
Have you ever feel any fainting?
No.
Okay. Lily, tell me, are you up to date on your cervical smear?
Yes, I'm up to date with it.
Okay. Please don't mind. I want to ask you some intrusive questions. Okay, Lily?
Okay, yeah, that would be fine.
Okay. Lily, tell me, have you ever seen for sexually shared infection?
No, nothing like that.
Do you practice any contraception like intrauterine device or progesterone only pill?
Before this pregnancy, I was just practicing condoms.
Okay. So condom is very good and it's a very safe practice to for the sexually shared infection, and I appreciate that. Okay, Lily, tell me, are you following your GP for any health issues?
No, doctor.
Any surgery in the past?
No,
In the kidney or down low? Okay. Are you allergic to any medication?
no, no, doctor.
Okay. Do you smoke, Lily?
No, I don't do that.
And what about alcohol?
Since I've become the pregnancy test came out to be
Mm-hmm.
positive, I stopped alcohol.
Okay, I appreciate that. And Lily, what's your blood group?
Yes, doctor, it is O positive.
Do you accept blood if required?
Yes, that would be fine.
Okay, Lily. Lily, I want to thank you very much for all the information. Do you want to add something?
Uh, Doctor, I'm here because previously I'm having two miscarriages. I
Mm-hmm.
have history. One miscarriage was done 7 weeks, and the other one as at 10 weeks. And the last
Mm-hmm.
one was 2 years back. And I'm quite worried that I don't end up again in this again miscarriage. That is why I'm here. Um, please do something. Please give me some medication that I don't end up again in miscarriage.
Okay, don't worry, Lily. I'm so sorry to hear that what happened with you, and I can. You have gone through a lot, and we are trying our best to help you. We as a team are here to help you, Lily. So please don't worry. Lily, I want to examine you in the presence of in the presence of Chevron. My nurse will check your BP, pulse, temperature, and I will see your tummy for any pain and do dental pervaginal examination to rule out any infection and bleeding. Is that right?
Okay, okay, that would be fine.
Okay, Lily. So now coming towards your concern, I want to tell you, Lily, that I want to tell you that at this point of time, uh, your ultrasound report is not showing that you have viable pregnancy.
What do you mean by
Are you
that,
getting?
doctor?
It means that I want to draw it for you that this is the womb and this is showing an empty sac and it's not showing any, pregnancy tissue in it.
Okay, so doctor, you can wait. You can wait 1 to 2 weeks, and the baby will appear in the scan. Sometimes you can repeat it, doctor. But I have told you I already have two miscarriages. Please give me some medication, some injections. My one of my friend got injections, and she ended up in successful pregnancy. Please give me that injection and repeat this scan. It would be a fine pregnancy because of early pregnancy. It might be a chance that the ultrasound is like that. Please don't
Mm-hmm.
say that that
Mm-hmm.
baby is not there.
Mm-hmm. I can understand, Lily. I can understand, and I can see your worries. And it's a very tough time for you, so don't worry. I want to tell you, I'm not saying that it's a miscarriage and other thing, but I want to do that. We have to run few tests for it. Okay, there is a pregnancy hormone which we see in your blood, and which we call beta HCG.
Okay, I offer you to for the beta HCG, and according to the limits of beta HCG, we can say that your pregnancy could be viable, and we will repeat it after 2 days, after 48 hours. And if it will keep on increasing, then it will be a viable pregnancy, and it would be a live pregnancy, and then you will be follow up in an antenatal care regular. And if it will decrease, then it would be a failing pregnancy, and then we will do your pregnancy test after 7 to 10 days. Okay, Lily, are you getting me?
Yes, I'm getting me.
And
So you are saying that the
yeah, yeah.
pregnancy is fine.
No, no, I am not, Lily. I am not saying that. I am saying that I want to run few tests. Okay, there is a pregnancy hormone in your blood which we will test. Okay, and if it will increases, then it means that pregnancy would be fine. And if it decreases, then it would be the failing pregnancy. And if there is no increase or decrease in the pregnancy hormone, then if there is a plateau, then it could be tubal pregnancy, which we called in medical terms ectopic pregnancy. Am I clear, Lily?
Okay, yes, I'm getting it, doctor.
Yeah, yeah. Lily, don't
Can
worry. We
you?
are here to support you. But yeah, yeah. Tell me.
Okay,
Mm-hmm.
so can you please explain my ultrasound report in detail?
Hello.
Can you please explain my ultrasound report in detail? Hello? Hello? Dr. Tabinda, are you there?
Human test.
Can you please explain my ultrasound report in detail?
Yeah, yeah. And please show me the. Hello, ma'am. Please show me the report. Yeah, it is showing that the pregnancy is in the womb, but it is an empty sac, and it is not showing any fetal pole. That means a pregnancy tissue.
Okay, so you will repeat this ultrasound report as well?
I will repeat this ultrasound report in 7 to 10 days.
Okay, okay. So doctor, if the report comes out to be fine, then I will be having a successful pregnancy, right?
Yes,
Okay. Okay, thank you, doctor.
thank you.
Okay, so starting from the feedback, Dr. Tabinda, it was basically a station of recurrent miscarriage. The patient has gave you, I'll go one by one with the domains and I'll tell you that where you went wrong. Overall it was a
Mhm.
good it was you tried to reach to the scenario, but some things were missed and that is why you got deviated. But some things I would like to tell you so that you can reach to the station and you can pick up what the station is. Starting from the information gathering, when the station was given to you, a patient has come to you with brownish vaginal discharge and the report has been shown to you. Based on your clinical experience, you can see that this is an irregular sac. Are you with me, Dr. Tabinda?
Yes,
So when
ma'am.
the
Yes, ma'am.
when an irregular sac is there, our all of us know from a clinical experience that irregular sac, even we repeat it or not repeat it, there is no chance that the pregnancy can be a successful pregnancy. The thing when there
Ma'am,
is
but we
proper sac,
often, yeah,
yeah,
ma'am, but we often repeat it, no, like in our
yes,
clinical practice. If a
Yes, you
patient
can
comes,
repeat it, but those
yeah,
are,
yeah.
but once there is irregular sac, there 90% chances that this is a missed miscarriage. You can say a safer statement. I will tell you. You can say that I can understand your concerns, Lily. The report that has been provided to me, it shows that the pregnancy is an irregular sac of this size, but to be sure, we will get a second opinion from the expert doctor or from the imaging doctor to see that what the scenario is. But I'm afraid to tell you that, I'm sorry to tell you that the report won't change, and it shows, it comes out to be a missed miscarriage. However, a second opinion will be taken. That is a better option. However, if you say that you will repeat it, there and then your applied clinical knowledge will go zero, because you are repeating a scan on irregular sac. You are not repeating a scan on blighted ovum. That are two different things. It is clearly, the college always gives an image to confuse you. An image you have to see very clearly. This is not a regular sac. All of you can see. So a better and a safe statement you can speak is, we will get a second opinion, because nice guidelines state that either you can take a second opinion or you can repeat it. And there is no good in waiting a patient who is already suffering from 3 recurrent miscarriages, and you make her wait 10 more days. You put her in more psychological stress. That won't be acceptable in the exam scenario, and that will just make your applied clinical knowledge to zero. So speak a better option, a better statement that we will get a second opinion. I will involve my consultant. We will get a second opinion from the senior radiologist. And that will just pass your domain. Don't make that mistake again. Coming from the, coming to the domains one by one, information gathering, because you didn't pick up the gist that this was a recurrent miscarriage. So definitely recurrent miscarriage information gathering was lacking. And I'm sorry that this wasn't a pass domain. You have to, according to the recent guidelines, 5 important things that you have to rule out in the recurrent miscarriage. You have to rule out APLS by asking any history of clots in you or your family. You have to rule out thyroid problems, any recent history of weight gain, weight loss, or heat or cold intolerance. You have to rule out diabetes. Any, by any chance, any blood test revealed any raised sugar levels. You have to rule out excessive hair growth, acne, PCOS. You have to rule out according to the recent Green Top guidelines, and you have to rule out prolactin. How? Any nipple discharge, any headache. So these were the very important question to ask in a patient of recurrent miscarriage. And another important, any history of anomalous babies in you or your partner's family. So all this was missing, and that is why this domain, I'm sorry to say, was not passed. Okay. The next domain was communication with the patient. You tried to be empathetic with the patient, but certain things were missing in the communication with the patient. When you were doing the Breaking Bad news, she wasn't aware of her ultrasound report. And before doing any Breaking Bad, what you have to do? Is it okay that is it okay that I call someone for support, or do you have someone with you for support? Because as I move further, because I'm afraid I don't have a very good news for you. Are you with me, Dr. Tabinda?
Yes, ma'am. Yes, ma'am.
Okay, so communication with patient, this thing was lacking. Okay, you tried to be empathetic, but you didn't do the proper way of Breaking Bad. And you always have to say, I've confirmed your name and NHS number. And I'm afraid that I have some difficult news. Your report shows that it comes out to be that the pregnancy is not showing some normal features. And I'm afraid it could be a missed
Yeah, ma'am.
miscarriage. However, we
Ma'am,
will.
ma'am, ma'am, sorry to interrupt you. I'm preparing for the first time. But whenever I do station in every ultrasound report, there are some, description in the below written like this is a gestational sac, this is the irregular. So I was not confusing. I was confused because of this. That I was not able to. Maybe I was not able to diagnose the case.
Okay.
That's why.
Yes, I totally understand. But college tries to give such figures, and some of the patients, some of the candidates are not even able to recognize what picture is that. Sometimes students mistake it for bladder. Sometimes students make it for blighted ovum. But try to see some of the images on the internet or some from books so that you are aware that what is a miscarriage. So that was missing information gathering. You didn't take the obstetric history. That is why you were not able to pass that domain.
Yeah, yeah,
I told
yeah,
you
yeah.
that I have two miscarriages. You didn't
Mm-hmm.
give any attention to the miscarriages. You have to ask when was
What
that
happened?
miscarriage? How did it happen?
Yeah, yeah.
How you came to know? These are few questions.
At
Then the
what
patient would
gestation?
have,
Yeah, yeah,
yeah, then the patient would
yeah,
have
yeah.
told you that first miscarriage was at 7 weeks, and I did a scan and they told me that the heartbeat is not there. They waited 1 week and then they gave me
Mm-hmm.
medication, and the other
Yeah, yeah,
miscarriage was bleeding on itself and everything just came out. So you always have to take the details.
that's
So
fine. Yes.
this was about the information gathering, communication with patient. I told you that a little bit of more empathy is needed, and breaking bad news signposting is
Mm-hmm.
required. Okay.
Mm-hmm.
And in examination, you were speaking 2 to 3 sentences. That is not required. You never have enough
Mm-hmm.
time to speak to give 1 minute to examination. Examination
Mm-hmm.
carries marks only in half of the stations. Just speak one sentence. Is it okay I examine you in the presence of a chaperone? Or you can speak at the minimum that is it okay I examine you from the tummy and down below? That's enough. Don't go in
Okay.
details. Don't go in details. However, if you have a patient of discharge or sexually shared infection, then add one sentence. And if we see discharge, we might take swabs. Try to just wind up in one sentence. The examination never
Mm-hmm.
carries many marks in half of the stations. You just have to get a tick. That was a mistake. Okay.
Yeah, yeah.
So once you reach to the diagnosis, then you have to empathetically in the examiner's key, it was there that the role player empathetically. This is a hot topic. It has been coming in the last few exams very repeatedly. You have to empathetically reveal the ultrasound report to the patient. So that was missing. Okay. Uh, the next thing was mm, beta HCG wasn't required. You mistook it for a pregnancy of unknown location, so that was a mistake.
Mm-hmm.
And once you
Mm-hmm.
have, so that is why applied clinical knowledge is not pass domain. That is a failed domain in this station. So once for all the other participants, I would like to tell that once you have made the diagnosis of recurrent miscarriage, according to the recent guideline, what management you will offer to the patient? You have to speak in a way. Lily, I'm sorry to tell you that we have made what seems most likely that this is a miscarriage. However, we will take a second opinion. I know this has come,
Mm-hmm.
this is quite hard on you. I know this has come as a shock to you. I will also connect you to the counselor, and my consultant will be
Mm-hmm.
here anytime, Lily. But based on this miscarriage, and you have two previous miscarriage, when this is the scenario, we call it as recurrent miscarriages. For this recurrent
Mm-hmm.
miscarriage, Lily, we are going to carry out certain investigations for you so that we can reach to the diagnosis and we can provide you the best possible care. Are you with me, Lily? The test that we are going to carry, because this is your third miscarriage, that we will send the sample to the laboratory to see whether there is some problem with the genes. We will take your blood samples to check for the blood sugar levels, and also some other tests for the thyroid will be carried out as well. We will carry out a special test for you to check for the sticky blood syndrome. We call it as antiphospholipid syndrome. Have you ever heard of that? In this syndrome, antibodies form that can make your blood sticky. We will check you for that as well, Lily. And we will carry out a detailed scan for your lower tummy to see whether we are missing something serious with the shape of the womb or structure of the womb. Are you following me, Lily? I know this is quite a lot of information. I will also provide you with the patient information leaflet, and you can take your time. You can discuss with your partner, and you can also discuss your concerns with my consultant as well. And Lily, once the results come out, and once we reach to the proper diagnosis, then in your next pregnancy, we will book you very early to the consultant-led unit. If it comes out to be sticky blood syndrome, once you become positive, urine pregnancy test positive, we will start you with the blood thinning injections and the aspirin, and we will follow you up regularly in the consultant-led unit. And if it comes out to be thyroid problem, we will give you certain medicines for the to rectify the problem of the thyroid. And Lily, if we are unable to find out any cause, then we will be providing you with the supportive care and the regular follow-up visits, because evidence suggests that only supportive care and regular visits can improve your chances of having successful pregnancy by about 75%. In this management plan and in this journey of your care plan, a team of doctors will be involved. That will include my consultant, the counselors, and a special clinic, recurrent miscarriage clinic. We will all be here to investigate you and provide you with the best management options so that you can have a successful pregnancy outcome. I know this is quite difficult for you, but we are here to provide you with a treatment option. My consultant would be here anytime to talk to you. If you have any concerns, do let me know. Thank you for your time, Lily. So this is how you are going to go with the recurrent miscarriage template. Okay, Dr. Tabinda? So
Yes,
for
ma'am.
me,
Thank you. Thank
okay,
you.
so for me, but I'm sorry, Tabinda, this time this isn't a pass station, and
Yeah,
unfortunately,
yeah,
none
ma'am.
of
I can understand because I didn't diagnose the case, so how can
yeah,
it
yeah, and
pass?
unfortunately, none of the domains was a pass domain. But don't worry, don't. This is just a start. You have got plenty of time. Gear
Mhm.
up, buckle up, start studying, study hard, and you have to do it in your first attempt. Good luck.
Thank you, ma'am. Thank you.
Okay, I guess the today's candidates one is missing, so I think we are done with the stations. Dr. Nazish, do you want to give the feedback? Over to you.
Okay, so Tabinda, that was a station. Basically, the problem was the diagnosis. Apart from that, your presentation was good. Like, if you practice more, then I'm sure that you can do it further better. And thank you for joining in as well. I would like to tell you a few points. Most of the points have been already covered by Dr. Sana. So there are a few points. One point is that starting from, I'm going to start from the agenda. In the agenda, most of the times we are seeing, like, before you joined in, I told Kim that there are some sentences that are repeatedly told by candidates, like, for example, if there are 14 candidates in a circuit and four or five out of them say the same typical sentences, then it gives a very bad impression that the things are being crammed up. So I heard that you said, okay, so we are going to give you a safe management plan. Believe me that every second person is saying the same line. So what impression it gives? It gives the impression that the candidate has simply crammed up the template, and the candidate is not going spontaneous. Isn't it so? You have learned this, right?
Yes, ma'am. Yes.
Yes, so please change it, because this gives a very bad
Mhm.
impression. Even when I was
Mhm.
going to appear for my exam, I received this feedback a lot, that just don't say the cramped things, because the reason is that every second person is saying the same. When you are going to say, okay, I'm going to give you a safe, acceptable, and mutually agreed plan, or you are going to say, okay, I'm going to provide you a safe management plan, and every second person is doing the same, what impression will it give you? Just keep yourself at the place of the examiner and think from their point of view. They will definitely think that you have crammed up the thing, so this gives a bad impression. Always be spontaneous in your agenda. There is no need for any fancy words. There is no need for any crammed up words. Just go simply, like, say, okay, so I have got your investigations along with me. I have got your ultrasound report, and we are going to discuss about that. And I'm going to offer you some management options. So this is not a crammed up thing. This is a spontaneous thing. Anything that comes out spontaneously in an agenda is a better option. What do you think about it?
Yes, ma'am. I
Okay.
was also
So
thinking.
yes, because the thing is not that you have said anything wrong. It is a good sentence. But the problem is that every second
Mm-hmm.
person is saying the same. And when every second person is
Yeah.
saying the same, how will you get any edge above them? Like, the people will think, the
Yeah.
examiners will think, okay, this is a crammed up sentence, and this is really very much discouraged about by the examiners. I met a layman examiner in UAE last year, so I listened from her. She was a layman examiner. She was not even an examiner. She told me that the doctors come in and they say a typical sentence that, okay, so we are here to give you a safe, acceptable, mutually agreed plan. And before the coital history, they say, okay, I'm really sorry to be asking this question. So she said that this gives a very bad impression to the lay examiner, that why are these doctors cramming up the things? So this is, I slightly discourage this thing. One was this thing. Okay, so the second thing was the history was slightly up and down. There was a fact that you didn't pick up the station, but the second thing was that the history was slightly up and down. Like I
Mm-hmm.
didn't get it why you asked the waterworks problem. Like, what was the link with that?
Mm-hmm. Yes, ma'am.
Okay, so the waterworks problem was, I don't think so that was important in this station. So anything that is not important in the station, just skip it because we need to complete our 10 minutes. So the history should be slightly organized. Obstetric history was very
Targeted.
important in detail. Okay, there was one
Mm-hmm.
thing in coital history you said, okay, please don't mind, and slightly you emphasized on it a bit more. See, when you are talking about the British people, they don't mind a lot when you ask about the coital history. You simply have to go, like, if you want to ask the coital history, and if it is important to ask, just say, okay, so I have a few personal questions. And then start asking. Don't say two, three sentences, please don't mind. I'm going to ask you personal questions. It's not required because for them, the sexual history is just like the medical or surgical history for them. It is not a big deal for them. So just a small sentence, okay, a few personal questions. I think that would be sufficient. Okay.
Mm-hmm. Yes,
Okay.
ma'am.
Then one point I noticed was the sympathy was slightly lacking. When the role player was very upset, you said okay, and then you started going on with your template. So I think the sympathy could have been a bit more, or at least you should have given a slightly more time to the role player to settle, or you should have offered that, okay, so you want, okay, so you could have offered some support, you could have offered her any water, or there should have been slight more sympathy than there was, because it was like you were not much sympathetic with the role player.
Ma'am, I
That
want to
was
ask
one
like,
thing. Yes,
ma'am,
please.
I want to ask like, I was not picking up, I was, anxious because I was not able to pick up the station. And
Okay.
so at that time, like, if it happens in exam, so that's why I was
Okay.
anxious and I was going here and there. So what should we do? Like, we should.
Okay, let me tell you that what exactly you should have done in this station. See, you saw an ultrasound, okay? So you got confused at what it is. You were somewhat, you knew that it is not a regular sac, but you were not very sure how to take it further. So in that case, it is a very good thing and it is a patient-safe approach. RCOG will never say that, okay, she didn't pick up the scan, so she is failed. They will never fail you. You should say that, okay, I can see your ultrasound report, but I need to be more sure about your report. And for that, I'm going to connect to my consultant. I will discuss your report with you and then I will get back to you. So, this is a very patient safe sentence. You are safe because you are connecting to your consultant because you didn't get the scan. So then you can say that, okay, so to me, it appears like it is not a regular sac and it is not going to be a viable pregnancy, or it is not going to be pregnancy. The pregnancy is not going to continue. But if you involve your consultant or if you involve the radiologist, you are safe for the patient. You will say, okay, so I can see your ultrasound and I am not very sure about the scan findings. So I have to connect to my consultant, and after discussing with my consultant, I will be in a better position to explain it to you. Like the candidate asks you, okay, explain my ultrasound with me. So you should have said, okay, I will discuss it with my consultant and then I will get back to you about the details of your ultrasound report. You can say that if you're not sure about anything. Okay. Am I clear, Tabinda?
Yes, ma'am. Yes, ma'am.
Okay, so because if you are not going to pick the ultrasound, they will not fail you. But if you are telling the wrong thing, then you can fail. Okay, so then one
Mm-hmm.
thing is that as far as I think, you have confused the pregnancy of unknown location with the recurrent miscarriage. See, there is a one very clear concept that when you see the pregnancy on an ultrasound, okay, when you see the pregnancy on an ultrasound, there is no role for beta HCG. Is there?
Mm-hmm. Yes, ma'am. Yes, ma'am. Right, right, very right.
There isn't. There isn't, right? Because see, if you even if you see a sac, irregular sac, okay, then what is the criteria? The criteria, according to the NICE guideline, says
Uh,
that when the gestational sac is 25 millimeters with no fetal pole, or if the CRL is 7 with no cardiac activity, then it is a missed miscarriage. Am I right?
Yes, ma'am. Yes, ma'am. Right.
Okay, and if there is an irregular sac, then definitely it is not going to be a pregnancy. So we simply have to say that it is not going to be a pregnancy is not going to. I'm afraid to say that this pregnancy is not going further. And however, I'm going to take further opinion from my consultant and from the imaging doctor in this ultrasound. Like there is no need to call her after 7 to 10 days because this is an irregular sac. If you have a sac like
Mhm.
25 millimeters and you cannot find a fetal pole, then you have to take another ultrasound. Or if you find CRL 7 millimeter and no cardiac activity, then you have to go for the scan. But in any case, if the pregnancy is visible on the scan, there is no need for beta HCG
Yes,
if it is
ma'am.
an
Yes, you're
intrauterine
right.
pregnancy. Right?
Yes, ma'am.
Right. So this was a small concept that was a slightly mixed. Basically, the thing was that the
Mhm.
ultrasound was not picked up, so you got slightly confused. But that's not a problem, because you can always put that on the consultant. You are an ST5 and you have full opportunity that whatever you feel like that you are not able to cope with that, or you have any difficulty in interpreting the scan, just put it on the consultant. Just say, I will talk to the consultant, I will check with my radiologist, then I will get back to you.
Mhm.
There is no need to give the wrong information, just put it on the consultant. This will be a patient safety.
Mhm.
Okay.
Okay, ma'am. Thank you.
Okay, so also because it was going to be a third miscarriage for her, so we will ask her that cytogenic analysis will be done after the pregnancy is over. And the recurrent miscarriage, basically the latest guideline has come, so has become very important. The history points, as Dr. San already told, like the prolactin, the raised sugar levels, PCOS, these all,
Okay.
the clots history, they have to be ruled out. Okay, so accordingly we can go. And accordingly we can offer the investigations, like if we cannot find any cause, then APLS can be checked, ultrasound can be checked. If there are any problems with thyroid, any excessive heat or cold intolerance, then thyroid test can be offered. And for PCOS, prolactin and diabetes, only if there are symptoms you can offer the test. So this is how this station goes. And regarding the recurrent miscarriage for all the students, I would like to tell that as I have already provided in the template as well, that's uploaded on your website. There are a few points from Meshre that you have to remember. One of them is like what are the uterine classification for genital tract abnormalities. That table has to be learned from Meshre, and a few points from Meshre are important. Like 3D ultrasound has the most diagnostic value in the any uterine anomalies, because the recurrent miscarriage is a station that is very important, and because the recent guideline has been published, so it is very important to know as well. So Tabinda, do you have any questions?
No, ma'am. Thank you, ma'am. Very nice.
Okay,
I really
it
like
was
the class.
really a very good attempt, and and your flow is really very good. If you just work on a few things, I'm sure you can do it. Okay,
Yeah, yeah. Thank you,
it
ma'am.
was good to have you. Okay, so any questions from any candidates?
Any questions? We will, me and Dr. Nazish, we will solve one station for
Okay,
you.
so if anyone wants to present one more station, we have one more station, because one of our presenter with three stations and one other presenter, two presenters are missing today. So if anyone is interested in one station, they can simply tell us, we can take them. Otherwise, Dr. Sana will be solving that along with me. Anyone wants to present?
Ma'am, can you please show the station?
Okay, then you will decide. Okay, you can see that, Tabinda.
Because, ma'am, I didn't read all the things till now. That's why.
Yeah,
Okay,
that's
I
fine. You
hope
can see if you can attempt that. You can see. This is, I think, a structured
structured
discussion.
discussion. Yes.
You want to do that, Tabinda?
Ma'am, I didn't read up till now. So please.
Okay.
Okay,
So,
okay.
dear candidates, this session will
Dr.
be,
Sana,
yeah,
Kim has not
yes.
presented a structured discussion. Kim may present.
Okay.
We
Oh,
can ask him.
Kim, Kim.
I can try.
Okay, yes.
Okay.
The one who tries always wins. Okay. So, Kim, this is a structured discussion. Okay.
Okay.
And you know the drill. You have 2 minutes. I'll give you 2 minutes to give it a read, and then I will start asking you questions. Okay. So
Okay.
here the
All right.
station is on your screen. Everyone, please mute your mic.
Okay. All right. Next page.
Okay, Kim. So I'll start the station now.
Okay.
You can start now.
All right. Hello, Doctor. I'm Kim, one of the candidates for the MRCOG Part 3 exam, and I'm ready for my structured discussion.
Okay, how are you today?
I'm fine. I'm
Okay. And how's your exam going?
it's a bit stressed, but I think I'm coping just fine.
Okay, good to know that. Okay, so Dr. Kim, could you please, you have read the scenario, and could you please tell me what other history or what detailed history you would like to take in this patient?
So in the situation, I'm noticed that I'm having a patient with a problem with nausea, vomiting in pregnancy. The history that I would like to take, number one, I would like to see if there is a significant weight loss, whether there is a weight loss of more than 5%, because I want to see whether am I dealing with a patient with a problem of hyperemesis gravidarum. And also, I would like to ask further history of another differential diagnosis pertaining to causing of the nasal vomiting in the pregnancy, such as any history of a urinary tract infection, if she have any history of thyroid problem before this. And then I would like to also ask another history, such as any headache or any blurring of vision, which might represent any space occupying lesion over the brain. And then I also would like to assess about her nausea and vomiting to assess for the puke scoring, because it will show that whether I can manage her either inpatient or I can just manage her outpatient based on the scoring and the severity of the nausea and vomiting. And I would like to ask further about the spotting. How bad is the spotting, the amount and the pattern of the spotting? Is there any possibility that I'm dealing with a molar pregnancy, which will having spotting with some vesicular-like structure? And also, I would like to ask whether she's this pregnancy, is it spontaneous or IVF? Because multiple pregnancy will be one of the causes of nausea and vomiting also. Then
Okay.
after that, I will ask about her allergies because I might need to start her on medication. And also would like to ask any other medical condition or surgery she had in the past. And then I would like to ask about her BMI because she might need some thromboprophylaxis for the current presentation. Yeah.
Okay. Okay. And what investigations you would like to carry out?
For the investigation, first of all, I would like to check her vital sign, whether to see her blood pressure, heart rate, and also her oxygen saturation to see whether there is any hemodynamic instability. Then I would like to take some blood investigation. There are few blood investigation taken, which is the full blood count and also renal profile. Mainly, I would like to see from the full blood count, is there any sort of infection? And then
Okay.
renal profile, I would like to see is there any renal impairment due to the dehydration and also any electrolyte imbalance. And
Okay.
I will also take some midstream urine to rule out any urinary tract infection. If the history is suggestive of any thyroid problem, then I will take some thyroid function test to see whether there is any hyperthyroidism.
Okay. Any
Then,
other tests? Any other
I would
tests?
like to do a scanning to
Okay.
see there is any molar pregnancy or multiple pregnancy. That will be one of the cause of the nausea and vomiting in pregnancy.
Okay. 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 So on ultrasound, it shows complete mole. Now tell me your initial management first, and then tell me your ongoing management.
For the initial management, I will admit this patient for the inpatient management because from the investigation, it showed that she are having electrolyte imbalance, which is she have a low sodium and also potassium. Then I would like to start her on antiemetic, and then IV drip with some potassium supplement in the drip.
How will you
Then
give that? How will you give that?
the potassium, I will count the potassium deficit. Normally for the IV drip, I will give a normal saline drip with KCl supplement based on the potassium deficit and also based on her weight.
Okay.
And then if there is any secondary causes, mainly because this is a molar pregnancy, then I would like to involve my consultant for the management of the molar pregnancy with consideration of the VTE prophylaxis later on because she has a bleeding. So for at this moment of time, the VTE prophylaxis might need to hold on. And then I would like to consider giving her thiamine because of the
Okay.
severe nausea and vomiting.
Okay.
Then
Okay. And what will be your
subsequent
ongoing management?
ongoing management, I will do the suction and curettage, and I will get
Okay.
in touch with my anesthetist for the early pre-meds to see whether this patient is fit for surgery. Then I
Okay.
would like to send her for suction and curettage, evacuate the molar tissues and send to the lab for the HPE confirmation. At the same time, I will manage the bleeding. If there is a bleeding in the operating theater, they might consider giving her tranexamic acid and also blood transfusion if the bleeding is massive.
Okay. And
Subsequently, I will get some beta HCG reading prior to the suction and curettage and after the suction and curettage. Then I will do a chest X-ray, knowing there is a molar pregnancy for the full assessment of the molar pregnancy.
Okay. And can you please tell me the follow-up of a complete mole and a partial mole?
For the partial mole, I will registered under the GTD center, And
Mm-hmm.
then I will monitor the beta HCG level through either urine or blood test. And then until it normalizes and two reading at least 4 weeks apart, then
Okay.
I will advise patient for the contraception until the completion of the follow-up. In a molar pregnancy, then the follow-up will depend on uh, how fast the normalization of the beta HCG level. If the beta HCG level is normalized within the 8 weeks post-suction and curettage, then the total duration of the follow-up will be 6 months from the date of the suction and curettage done. However, if the beta HCG level is
Mm-hmm.
a bit slower to be normalized,
Mm-hmm.
then I will continue the follow-up 6 months. 6 months after the
Mm-hmm.
normalization of the beta HCG level.
Okay. And what will you advise this patient that how long she has to do the contraception and what contraception you will prescribe her?
The contraception in general, except for the intrauterine device, she can use a barrier method. And then
Okay.
once the normalization of the beta HCG, then she can use all method of contraception.
Okay.
During the follow-up, she need to be on the contraception during the 6 month
Mm-hmm.
until the completion of the follow-up.
Mm-hmm.
If she might need chemotherapy, then it's advisable that she didn't get pregnant at least 12 months from the last chemotherapy.
Okay. And in her next pregnancies, would you advise her to do urine pregnancy test after every pregnancy?
Actually, if the molar pregnancy doesn't need any chemotherapy, then she might not need any further beta HCG testing in her next pregnancy.
Okay. Okay. Thank you, doctor. Time's up.
All
Okay.
right, thank you.
Very well done. Very good, Kim. I'm quite impressed. You have a very good grip of knowledge. And your applied clinical knowledge is excellent. Your knowledge is fresh, and you are a very good candidate for MRCOG Part 3 May attempt. And I have full confidence in you. And I have full confidence that you will pass with flying colors. And based on this, that how you have tackled this station and how you have touched every domain, that is quite impressive. Excellent. Excellent. This is a total pass station. However, some things I have to tell you so that you can improve. In history, when I told you that was very good, you told about the weight loss. But when I told you about the nausea and vomiting, you can just add that I will ask the patient to elaborate on the vomiting and to the nausea about the frequency and is it more to solids, is it more to liquids? So you can add a few questions like that. Are you with me, Kim?
All right, yeah.
Okay, so this thing was missing in the history, and you ruled out other causes of nausea and vomiting. You ruled out raised blood sugar levels. You ruled out urinary tract infections. You ruled out any other problems, any infections, any thyroid problems. That was all ruled out. That was very good. Just a little bit more you can ask about the vomiting episodes and whether it is more to the solids or to the liquids. That was missing. And when I asked you the investigations, so you started with that I will examine. So when the examiner is asking straightforward about investigations, don't add examination. Okay, that gives a bad impression that the candidate is not attentively listening. We have asked about investigations and he has started with examination. Okay, so try to avoid
All
that. When the investigations are there, only stick to investigations. Investigations, you have touched all the investigations. You skipped beta HCG, but in the management, you touched that as well. So beta HCG was missed and scan ultrasound was done. That was quite impressive. Always, always, always try to mention all the investigations, possible investigations or relevant investigations, because in most of the scenarios, in most of the stations, there are guidelines from the college to the examiners that reveal the investigations to the candidate once he asks for it or once he mentions it. So if you wouldn't have mentioned ultrasound, I wouldn't have you given the scan that it is a molar pregnancy. So try to mention all the investigations, relevant investigations, because examiner most of the time has investigations and they reveal the investigations once you mention it. So if you don't mention it, you can't pass the station. So mention the investigation and the examiner will give you the report or will tell you, because it has happened many times in most of the stations. This happens. Investigations were touched. uh, Initial management, you definitely tackled it very well when a patient with hyperemesis and molar two scenarios has come. So in initial management, you will tell the initial resuscitative management or the initial management that you will give to the patient, and in ongoing management you will tell the definitive management. So you did the same. This is very important because examiners get fed up, examiners get irritated if in initial management you tell all the management, you tell the suction evacuation in the initial management. Never do this mistake. Always tell your definitive management, your surgical management, your suction and evacuation management in ongoing management. In initial management, just tell initially what will you do, because examiners just get irritated and they give you borderline marks. Initial management of hyperemesis patient is just to admit, just to give fluids, avoid glucose, and give thiamine and thromboprophylaxis. So just tell initial management so the examiner doesn't get fed up. And when he asks about ongoing management or further management, then explain the definitive management. One thing was missing, Kim. You can ask, you can give it a read from the templates that how to give the fluids. That is written in the template. Just memorize that. First we gave 1 liter in 2 hours, and then we give the other over 4 to 8 hours. So just revise that.
Okay.
Okay. So that was just missing in ongoing management. And there is an examiner key that if a patient in hyperemesis misses thromboprophylaxis, he can never pass that station. So you touched thromboprophylaxis, you passed the station, and you touched ongoing management, good, and the follow-up was right on point. So from me, it is a total pass station and very well done.
Thank you, Dada.
Keep it up, keep it up.
All right.
Okay. Okay, so when did you give the MRCG2 exam, Kim?
I'm MRCU last year, January.
Okay, so your knowledge is fresh.
Yeah.
Okay. Okay, so we are done with the presentations. One station I'm going to solve for you, for the candidates, to how to see how to speak. And this last station, I just want you to take the screenshots and you have to read it from the guidelines and search answers, write answers, and then you can text me that these are the, and then I can check it for you, but take the screenshots. Okay, candidates? The questions are, there's a patient with recurrent miscarriage. What investigations you would like to order? You have to study recent green tub guidelines. You have to give a read once to ASHRAE guidelines to see what are the types of uterine anomalies. You have to memorize it because it is also a hot question. Then you have to study the treatment options and investigations for anomalies of the uterus from the ASHRAE guidelines. And recent green tub guidelines, give it a good read and memorize it, just the summary, just the highlight points. Okay, so this is the last station because one candidate is missing, so this won't be possible to solve, but you can screenshot it and then you can solve it yourself or send it the video notes. Okay, candidates? Okay,
Okay.
so I will solve one station for you. Just give me 2 minutes break and then I will just solve it for you guys. Okay, bear with me and I'll just be back. Okay.
Okay, so there is also one request from me to all the candidates because in the current batches we are only taking like 4 active candidates for the presentations. So I would really request that the candidates should we keep the time according to the active presenters time zone. Like Kim told me, Dr. Amna told me, and some other candidates also told us the times that what times are suitable to you. But today 1 or 2 of the candidates were not present. But please try that we are not taking big batches at the moment because we want that we can get maximum number of presentations from the active presenters, and for that I would really request that you should tell us the time prior, so that none of you is missed. Because if one candidate is missed, then two stations will go missing. So we do not want to do that, and we want you to have the maximum participation, because at the end of the day, the more you are going to participate, the more you are going to learn. And the more when the mistakes get corrected, they stay in our mind for a slightly longer period of time. So also, I'm going to tell you that the next station is going to be on urogynecology. I'm going to take advantage of Dr. Sana's 2 minute break. So next station is going to be urogynecology for everyone. And in the urogynecology, I have noticed that many people find it really tough to interpret the charts or the urodynamic charts. So I'm going to keep the stations brief, like there will be 5 to 6 stations as a total. And before the going on to the presentations by the candidates, I would explain them to you that how you have to interpret the charts. And after that, hopefully you will never find it difficult to interpret the charts. Apart from that, in urogynecology, is there any concept that you want me to incorporate? Any student? Okay.
Doctor,
Yes, please.
does the pop Q, is it they going to ask us to do, or they just ask us to interpret the pop Q in exam?
Okay, so Kim, let me tell you that it was my exam question. And whenever a pop Q station comes, first of all, we go towards okay, whether it is a bullying station or it is a pop Q station. But at the end of the day, you have to know very well about the pop Q. And it is going to be taught in the teaching station. In the teaching station, we have kept the pop Q station, in which we will tell you the exact way that how you are going to. I'm going to give you some really good diagrams, and I will teach you about the pop Q as well. So, do you want me to include it in the gynae station, like in the urogynecology stations?
Yeah, in the pop Q, yeah. I
Okay,
mean,
okay, I will do that. What we can do is that after the presentation of the prolapse, I will teach you PopQ, okay? And I'm also
okay.
going to teach you some things about urogynecology that you find difficult. I have seen that students find it difficult to interpret the charts. So, the regarding the stress urinary incontinence, mixed incontinence, sensory urgency, and then we have the overactive bladder disease or overactivity. So the students are kind of confused that how we interpret these charts, but these charts are very easy to interpret, and I'm going to discuss them with you as well. Is there anything else that you want me to incorporate? Okay, so Kim, you asked me one question that how to tackle the difficult role player. So Kim,
Yeah,
can you tell me that there are different the kind of difficult role players? Like sometimes there is a role player who is crying, like the Prasanna did that once in a station today. Then there is a kind of patient who does not say anything. Then there is a kind of patient who gets aggressive. Like what kind of difficult role player? Tell me some scenario, like what kind of role player it is, so I can tell you accordingly.
yeah. For example, like the station on the recurrent topic. Let's say if there is the patients like insisting that she doesn't want surgery, that she, even though we say the surgery will be the best option, they say I don't want because I have already one tube gone, but I want to save my another tube. Is there any way that we any words that we should use to tackle the situation?
Okay, yes, this is a really good question, and according to our today's topic as well. So, Kim, in this situation, the best thing is that you cannot say the patient from the very beginning that no, I am not going to do that. Okay, never
Mm.
say the patient, I am not going to do that. Even if you think that is not a suitable option for the patient, just take it this way that okay, so start like the patient says you about the medical management. Start with the medical management. Okay, so we have one option in which we can provide you with some medication that can be given to you in the muscle, but I am afraid that with this option this can happen. Okay, so if she is not a candidate for the medical management, then simply tell her that because of this criteria it is not a suitable option, but first of all address her option, like say okay, I can provide provide you with the medical management. However, these are the problems that can be anticipated with the medical management, like the pregnancy may continue and you may require a surgery. There is a very famous thing that is called as sandwich technique, which comes in negotiation. What it means is that the thing that you want the patient to admit, say it like, for example, if you want the patient, you want to give her the option of surgery. First of all, tell the medical management its benefits. Then tell the disadvantages of the medical management. Okay. Then tell the surgical managements, tell the disadvantages of the surgical management. At the end, tell her that what are the advantages of surgical management. Because at the end of the day, do you want her to pick up surgery? So in the end, tell her what are the benefits of the surgery and what are the problems that can come with the medical management. Okay, just tell her that the pregnancy can continue. There are more chances that the pregnancy will continue, and there are more chances that you might need a repeated surgery. There are chances that the tube might rupture and you might require an emergency surgery in which the tube will have to be removed completely. So just tell her that if she will go for an emergency procedure, she may end up into a very life-threatening hemorrhage. She may end up into the self-injectomy. She will end up into a laparotomy. Just tell her the options, because when the patient will know that how dangerous it is for her, then she will admit your option. But it is not wise thing to say her from the very start that no, don't go for medical management. Just tell her, okay, medical management is one of the options, but it is an option when this criteria is met, but it has these disadvantages. Then tell the surgery its disadvantages, and it has more advantages in her condition this way. Could I make it clear?
Yes, yes. Yeah. It sounds nice. Now I understand.
Okay.
Okay, so
Okay.
it must be very late for Kim. So, Kim, what is the time in Malaysia?
Now it's 2:45 a.m.
Okay. Okay, so
Oh,
we'll just
it's
finish the
2:45 a.m.
we'll just finish the lecture so that you can have some beauty sleep. So we'll
All
just
right.
finish the lecture. Okay. Okay, so I'm going to perform this station for all the candidates, and this whole lecture is going to be uploaded by tomorrow in the website, and the candidates who couldn't attend can listen to this as well and make notes. And if you have any queries or you want to listen to any station, that would be available to you till the date of exam. You can listen anytime to this station. So by tomorrow, you will be able to access. So I will just solve the station for you guys. Okay, so this station, okay. Hello, I'm Dr. Sana, one of the doctors in the early pregnancy assessment unit today. May I please know your name and age? Okay, is it okay I call you Susan? Susan, I've gathered from your notes that you are here because you're having some pain. Is that right? Okay, so Susan, in the coming few minutes, I will be discussing the management options with you, and I will try to address your concerns. But before that, would that be fine that I ask you a few questions? And at the end, I will write back to your GP and provide you with the patient information leaflet. Okay, thank you, Susan. Okay, Susan, could you please tell me in detail about your concerns? Can you elaborate more on the pain? Can you score the pain for me? From 0 to 10, 0 being no pain and 10 being most severe pain? Okay. And are there any factors that aggravate the pain or that relieve the pain? Okay. Is this pain associated with any nausea, vomiting, fainting episode, or dizzy spells? Any episode of bleeding? Okay. Any shoulder tip pain? Can you elaborate more on the spotting? Okay. Was it associated with any clots, vesicles? How many pads you soaked? Okay. Was there any triggering factor for the bleeding? Okay. Susan, I've gathered from your notes that your urine pregnancy test, home urine pregnancy test came out to be positive. Okay. So could you please tell me that how far are you in your pregnancy? Okay. And is this your first visit? So you have been to the midwife. Have you been taking folic acid? Good to know that. Okay. And is it a planned one? Okay. A few other questions. Is this your first pregnancy? Were your periods regular and normal before that? Okay. Sorry to ask a few personal questions. Any history of sexually shared infection in the past? Any multiple sexual partners? What contraception you were practicing? Okay. Any medical problems? Any surgeries? Any family history of concern? Do you smoke or drink alcohol? Sorry to ask, any recreational drugs? Any allergies? Your weight to height ratio? Blood group? Any reservations to the transfusions? And what do you do, Susan? Okay. How's the sport at home? So, do you consider yourself to be a happy couple? What are your partner's thoughts on this pregnancy? Thank you for providing me with all the information, Susan. Is there anything you would like to add that you think will help me in management today? Okay. Is it okay I examine you in the presence of a chaperone from tummy and down below? Okay. Susan, do you need someone to accompany you while I proceed further? I'm afraid I have some difficult and concerning news to discuss with you. Susan, I've got your reports here. I've confirmed your name and NHS number. The reports belong to you. Your pregnancy test shows that urine pregnancy test shows that you are pregnant. That comes out to be positive. But I'm afraid that there are some concerning features on the ultrasound report. There has not been seen any pregnancy on the ultrasound report. I'm sorry to tell you that, but when this is the scenario that pregnancy hormone report comes out to be positive and ultrasound does not reveal any pregnancy, we call it as pregnancy of unknown location. Have you ever heard of that? Susan, there could be three possibilities. Either the pregnancy is in the womb, but it is too early to be seen by the ultrasound, or the pregnancy has miscarried already, and that is why it is not visible on the ultrasound. And the third possibility is that the pregnancy is outside the womb and it is too early to be seen on the ultrasound. That could be a serious condition. We call it as ectopic pregnancy that needs to be ruled out before we can proceed with the further management options. Are you with me, Susan? Any questions so far? Susan, from this point onwards, you will be managed by the team of doctors that will include my consultant, imaging doctor, counselors, and a specialized nurse. They all will be involved in your care plan. What we are going to do, that your hormone report is here, pregnancy hormone report, we are going to repeat it 48 hours later. And we will be comparing the two reports. If it has increased or it has doubled, then it means that the pregnancy is inside the womb, and we will repeat the scan in a week's time to be sure. If it decreases significantly within the 48 hours time, it means that the pregnancy has been miscarried. In that case, we will repeat a pregnancy hormone test or urine pregnancy test within 7 to 10 days time. If it has remained static, the pregnancy hormone report comes out to be static, or it has just slightly increased, then it could be a concerning situation. In that case, it could mean that this is pregnancy outside the womb or ectopic pregnancy. Are you with me, Susan? I know I have provided you with a lot of information. I will also give you the patient information leaflet as well. Do you want me to repeat anything? I understand your concern, Susan, but once we are sure of the location of the pregnancy, then we will proceed with the management option. But one thing I would like to assure you, Susan, that every woman has a right as to when, where, and how she wants to deliver. Your choice will be respected and supported. We are just here to guide you with the choices. But different locations of pregnancy have different management options, and we cannot proceed with the management option once we confirm the location of the pregnancy. Once it is confirmed, then we will discuss you with the management options for you, whether you want to continue or end up the pregnancy, and the options for both will be discussed in detail. I know this is quite difficult for you and you could be finding it difficult to cope up with. I will also be connecting you to my consultant to address your concerns and to a counselor for a better coping. Would that be fine? And once you decide for this pregnancy, then I will arrange an appointment for you to discuss some long-acting reversible contraceptive methods to avoid unwanted pregnancies in the future. Would that be fine with you? Thank you for that. While we repeat this hormone report, 48 hours time, Susan, if you feel any fainting, any dizzy spell, or you think that the bleeding is getting heavier or pain is getting severe, please report us to immediately without any delay. I will also provide you with the 24/7 contact number of the Early Pregnancy Assessment Unit, and you can drop to us anytime. My consultant would also be here anytime. Thank you for talking to me. Here is the patient information leaflet and support group. Thank you for your time. Okay, so this is how you are going to do this pregnancy of unknown location scenario, and you can also listen in the recordings and then you can make the notes for you as well. Okay, so this was today's session for early pregnancy care. And if any candidate has any questions, now we are open to questions. Okay, I guess no one has question. Now start studying urogynecology module and study hard, and we hope to listen to some amazing presentations next time. And if you have any queries, you can drop to us anytime in the group. And if you want to share any audio notes or audio voice notes, you can drop anytime in the group, and we will be very happy to share the feedback. Thank you for all for your time, and thank you for the class. See you. Bye bye.
Okay, so goodbye everyone. And one thing is that all the templates for the next urogynecology have already been uploaded on the website, and you can take help from them. Again, one thing, don't cram them up, but just take a good concept and good points from them. So we wish you very happy studying, and if you feel like any problem, just ask in the group, and we will be open to answering you that. And take care everyone, and goodbye.